Hello and welcome to your ultimate guide for the ATI Pharmacology. My goal today is simple: give you everything you need to fully understand the key concepts, master them, and walk into your ATI Pharmacology exam with total confidence. In this video we'll cover drug toxicology, adverse effects, patient education, medication safety, contraindicated sites. With over 100 plus success stories, we have proven our videos will help you pass your exam on the first attempt. And remember, our website offers free exam guides and practice questions to help you ace your ATI Pharmacology exam. You'll find the link in the description below, so be sure to check it out and get the resources you need to study smarter, not harder. So let's get started.
Question 1. A nurse is caring for a client who is receiving IV mannitol for cerebral edema. The client develops dyspnea, crackles, and distended neck veins. Which of the following actions should the nurse take first? Your options are: A. Stop the infusion. B. Increase the infusion rate. C. Place the client flat. D. Encourage oral fluids. Which one is it? Pause the video if you need more time. The correct answer is A. Stop the infusion. A is correct because dyspnea, crackles, and distended neck veins indicate fluid overload and pulmonary edema, a serious mannitol complication. The nurse should first stop the infusion to prevent further fluid from entering the vascular space, then notify the provider. B is wrong because increasing the rate would force even more fluid into an already overloaded circulation, intensifying the pulmonary edema. The safe first action is to halt the drug, because speeding it up directly worsens the very problem the client is showing. C is wrong because lying the client flat would worsen breathing and increase venous return to an overwhelmed heart. The priority is to stop the offending infusion. Positioning may follow, but it does not address the source of the fluid overload. D is wrong because offering oral fluids adds volume to a client who already has too much, deepening the overload. The first and most protective step is to discontinue the mannitol, since continued or added fluid is what threatens this client. Mannitol is an osmotic diuretic, a sugar alcohol that stays in the bloodstream and tubules rather than being reabsorbed. That single property drives everything it does, both therapeutically and dangerously. Once infused, mannitol raises the particle concentration in the blood, pulling water out of swollen tissues and into the vessels. The kidney then filters the drug, which holds that water inside the tubule, and a large volume of urine leaves the body. Clinicians reach for mannitol when tissue pressure must fall fast and most often a swollen brain trapped inside the rigid skull, or dangerously high pressure inside the eye. The drug borrows water from where it is harmful and moves it to where the kidneys can flush it out. The timeline has two distinct phases. First, circulating volume swells as water floods in from tissues, a window where a weak heart can be overwhelmed. Then, the kidneys excrete the mannitol and the water pours out and the risk shifts to dehydration. When the heart cannot handle the extra volume, fluid backs up into the lungs and venous system. Shortness of breath, crackles at the lung bases, and bulging neck veins appearing during a mannitol infusion all point to circulatory overload. And the immediate protective move is to stop the infusion. Question 2. A nurse is admitting a client who has severe aspirin toxicity. Which of the following findings should the nurse expect to assess in this client? Your options are: A. Low body temperature. B. Cool dry skin. C. Lung crackles. D. Respiratory depression. Take a second. Which answer would you pick? The correct answer is D. Respiratory depression. D is correct because severe aspirin toxicity progresses from salicylism to acidosis and respiratory depression as the salicylate level climbs. The nurse should expect slowed, depressed breathing and treat this presentation as a medical emergency that requires close monitoring and prompt intervention. A is wrong because aspirin toxicity raises the body temperature rather than lowering it. The client typically develops a high fever, so a low temperature would be an unexpected and inconsistent finding for the nurse to assess during this emergency. B is wrong because heavy sweating accompanies aspirin toxicity, which leaves the skin moist rather than cool and dry. Because diaphoresis is part of the clinical picture, dry skin does not fit the presentation the nurse should expect with this client. C is wrong because crackles suggest fluid in the lungs, but aspirin toxicity instead causes dehydration from fever and sweating. The breathing problem here is depressed respiration, not the fluid overload that would produce crackles on auscultation. Salicylate toxicity isn't a single event. It's a stage cascade that unfolds as blood levels rise. Understanding why aspirin behaves so dangerously in overdose helps explain every sign and symptom on the clinical picture. In normal doses, the body clears salicylate steadily, but the clearance pathways saturate in overdose. Small increases in the amount swallowed cause large, unpredictable jumps in blood level, sliding a patient from uncomfortable to critically ill far faster than expected. Two mechanisms drive the early picture simultaneously. Salicylate directly stimulates the brainstem breathing center, causing rapid deep breathing that blows off carbon dioxide and creates respiratory alkalosis. At the same time, it disrupts cellular energy production, generating heat and acid, producing fever, heavy sweating, and metabolic acidosis. Early toxicity is marked by rapid deep breathing, tinnitus, fever, and sweating were driven by stimulation. As levels climb further, compensation fails. The breathing center becomes depressed, respiration slows and shallows, and acidosis deepens. This shift from stimulation to depression is the critical pattern to recognize. The finding that trips people up most often is the breathing direction. Early salicylate toxicity speeds breathing up, severe toxicity slows it down. Slowed, failing respiration is the ominous sign that marks a true emergency, demanding immediate airway support. Question 3. A nurse is caring for a client who is receiving a neuromuscular blocking agent during mechanical ventilation. Which of the following is the priority nursing consideration? Your options are: A. The client cannot feel pain from the drug. B. The drug improves the level of consciousness. C. Continuous respiratory support must be maintained. D. The medication relieves the client's anxiety. Before I reveal it, which one do you think is right? The correct answer is C. Continuous respiratory support must be maintained. C is correct because neuromuscular blockers paralyze the respiratory muscles, so the client cannot breathe independently during therapy. Maintaining continuous mechanical ventilation and respiratory support is the priority in order to keep the client safe throughout the period of paralysis. A is wrong because neuromuscular blockers do not affect pain perception, so the client may still feel pain and need separate analgesia. This makes pain management a real concern rather than a reassuring feature of the drug for the client. B is wrong because these agents have no effect on consciousness or thinking at all. They paralyze the muscles without sedating the client, so they do not improve the level of consciousness as this option incorrectly states. D is wrong because these agents act only on muscle, they cannot relieve anxiety in the client. Separate sedation is required for comfort, so anxiety relief is not something this medication provides during the period of paralysis. Neuromuscular blocking agents paralyze skeletal muscle by interrupting communication between the motor nerve and the muscle fiber. Understanding how they work and what they leave untouched is essential to managing patients safely. Normally, the nerve terminal releases acetylcholine, which binds to receptors on the muscle and triggers contraction. Blocking agents occupy those receptors, so the signal never lands and the muscle goes completely slack. Precise muscle relaxation gives surgeons a still operative field and allows a ventilator to deliver breaths without the patient farting the machine, making both situations safer and more controllable. The blocker handles the muscles only. It does not sedate and does not block pain. The brain stays fully aware. Sedation and analgesia must always run alongside the blocker because the drug that stills the body does nothing for the mind inside it. The diaphragm is skeletal muscle, so it is paralyzed too. The patient cannot breathe at all. Mechanical ventilation, continuous monitoring, sedation, and pain control are non-negotiable for as long as the blockade lasts. Question 4. A nurse is teaching a client who has a new prescription for hydrochlorothiazide. Which of the following findings should the nurse instruct the client to report as a sign of a low potassium level? Your options are A. General muscle weakness, B. A bluish color to the urine, C. Ringing in the ears, D. A metallic taste in the mouth. What's your answer? Commit to one before I continue. The correct answer is A. General muscle weakness. A is correct because hydrochlorothiazide wastes potassium and hypokalemia produces general muscle weakness, fatigue, leg cramps, and nausea. The nurse should teach the client to report weakness so the provider can evaluate and replace potassium before cardiac problems arise. B is wrong because a bluish tinge to urine is associated with triamterene, a potassium-sparing diuretic, and is harmless. It is not a feature of low potassium, which announces itself through muscle and cardiac symptoms rather than a change in urine color. C is wrong because ringing in the ears warns of ototoxicity from loop diuretics. Thiazides carry no hearing risk. Low potassium does not affect the ears, so the client should instead watch for weakness and cramps as the signal to call the provider. D is wrong because a metallic or altered taste links to captopril, an ACE inhibitor, not to a potassium deficit. Hypokalemia is recognized through weakness and muscle cramps, so taste changes are not what the nurse asks this client to report. Hydrochlorothiazide is a thiazide diuretic that lowers blood pressure by changing how the kidney handles salt. To understand why it causes muscle weakness, we need to follow what happens inside the distal convoluted tubule. Thiazides block the sodium chloride cotransporter in the distal convoluted tubule. With reabsorption blocked, sodium stays in the tubule, water follows, and the extra fluid is excreted as urine. That is how the drug reduces fluid overload and blood pressure. The problem is that the kidney responds to extra sodium arriving in the final tubule segment by reabsorbing some of that sodium in exchange for potassium, which is then excreted. Over time, the steady trade drains the body's potassium and produces hypokalemia. Potassium is what muscles and nerves depend on to fire and relax in rhythm. Early hypokalemia announces itself as muscle weakness, fatigue, and leg cramps. Left unchecked, falling potassium can disrupt the heart's electrical rhythm and cause dangerous arrhythmias, which is why those early muscle symptoms deserve prompt attention. The classic exam trap is mismatching symptoms to drugs. Ringing in the ears belongs to loop diuretics, and a metallic taste belongs to ACE inhibitors. Low potassium from a thiazide speaks through muscles and the heartbeat, not through color, hearing, or taste. Keep that link straight and you will not be fooled. Question 5. A nurse is teaching a client who has been using a topical nasal decongestant such as phenylephrine for several days. Which of the following adverse effects results from prolonged use? Your options are A. Sedation, B. A productive cough, C. Constipation, D. Rebound congestion. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D, rebound congestion. D is correct because prolonged use of a topical decongestant beyond a few days leads to rebound congestion, in which nasal stuffiness worsens. The nurse should teach the client to limit topical use to the recommended short period in order to avoid this effect. A is wrong because sedation is not the concern with topical decongestants, which tend to stimulate rather than sedate the client. Rebound congestion, not drowsiness, is the effect that results from using a topical nasal decongestant for too long. B is wrong because a productive cough is unrelated to overuse of a nasal decongestant. The hallmark of extended topical decongestant use is worsening nasal congestion, so a cough is not the adverse effect that results from prolonged use here. C is wrong because constipation is not associated with these topical agents. The problem caused by using a topical decongestant for longer than the recommended period is rebound nasal congestion, rather than any change in the client's bowel pattern. Topical nasal decongestants like phenylephrine work by stimulating alpha-adrenergic receptors on blood vessels in the nasal lining, causing them to constrict. This shrinks swollen tissue quickly, bringing fast, targeted relief, usually within minutes. Because the spray acts directly on the nasal tissue rather than traveling through the bloodstream, relief is fast and systemic side effects are minimal. For a short cold, this is genuinely useful, but the word short is critical. With repeated dosing, two things go wrong. First, tachyphylaxis sets in. The vessels become less responsive, so each spray does less. Second, when the dose wears off, vessels rebound by dilating even more than before, making congestion worse. The user sprays again for relief, tightening the cycle, a pattern called rhinitis medicamentosa. The trap is that the drug appears to keep working while quietly becoming the cause of the very problem it is meant to fix. The spray feels essential, but it is the spray itself driving the worsening congestion. The remedy is stopping the spray and allowing vessels to recover their normal behavior, recognizing the signal. Worsening stuffiness despite faithful use of a topical nasal decongestant, is the key clinical insight. Question 6. A nurse is teaching a client who has a new prescription for metformin. Which of the following findings should the nurse instruct the client to report to the provider? Your options are A. Mild constipation, B. Slight weight gain, C. Muscle pain with unusual drowsiness, D. Increased appetite. Which would you go with? Lock it in before the reveal. The correct answer is C. Muscle pain with unusual drowsiness. C is correct because muscle pain with unusual drowsiness can signal lactic acidosis, a rare but serious metformin complication. The nurse instructs the client to report these findings promptly so the provider can intervene. A is wrong because metformin tends to cause diarrhea rather than constipation, and mild bowel changes are not the urgent concern. The reportable warning is the cluster pointing to lactic acidosis, not constipation. B is wrong because metformin commonly causes loss of appetite and weight loss, not weight gain. A slight weight change is not the serious sign the client must report, unlike the symptoms of lactic acidosis. D is wrong because metformin often decreases appetite, so increased appetite is not an expected or alarming effect of the drug. The pairing of drowsiness with muscle pain is the truly dangerous finding that should prompt a call to the provider. Metformin is the cornerstone of type 2 diabetes treatment, but understanding why it works and where it can go wrong is essential for anyone caring for patients on this drug. Metformin belongs to the biguanide class and tackles type 2 diabetes at its root, too much glucose from the liver and tissues that have become resistant to insulin. Because it doesn't push insulin levels up, it almost never drives blood sugar dangerously low on its own. Metformin shifts cellular energy metabolism in a way that nudges lactic acid production upward. Healthy kidneys clear both the drug and that acid easily. But when kidneys are failing, severe dehydration strikes, or serious illness intervenes, the drug accumulates and lactic acid builds faster than the body can clear it, leading to lactic acidosis. Lactic acidosis doesn't announce itself dramatically. It whispers through muscle pain, unusual drowsiness, weakness, and trouble breathing. The cluster of these symptoms, especially in someone on metformin with dehydration or kidney trouble in the background, is the warning that demands immediate attention. Loose stools and metallic taste are common, tolerable side effects that often fade. But muscle pain, drowsiness, and labored breathing together point to lactic acidosis, metformin's one truly dangerous complication, and the one that can be fatal if missed. Question 7. A nurse is teaching a client who takes a centrally acting alpha-adrenergic agonist, such as clonidine, and wants to stop the medication. Which of the following instructions should the nurse include? Your options are: A. Taper the medication gradually as directed. B. Stop the medication abruptly to avoid side effects. C. Double the dose before stopping. D. Skip doses every other day to wean off. Don't overthink it. Which one feels right? The correct answer is A. Taper the medication gradually as directed. A is correct because abruptly stopping a centrally acting alpha-adrenergic agonist can cause rebound hypertension in the client. The nurse should teach the client to taper the medication gradually under provider guidance in order to avoid a dangerous rise in blood pressure. B is wrong because stopping abruptly can trigger rebound hypertension rather than avoiding side effects for the client. A gradual taper guided by the provider is required, so sudden discontinuation of this medication is unsafe and should not be taught. C is wrong because doubling the dose before stopping does not prevent rebound effects and could cause excessive sedation or low blood pressure. The correct approach for this client is a gradual taper, not an increase in the dose. D is wrong because randomly skipping doses produces unstable blood levels and does not safely wean the client from the drug. A structured, slowly step-down dose under medical supervision is the appropriate way to discontinue this medication safely. Clonidine lowers blood pressure by acting inside the brain, not directly on blood vessels. Understanding how it works and what happens when it stops is essential for safe practice. In the brainstem, alpha-2 receptors act like a brake on the sympathetic nervous system, the system that speeds the heart and tightens vessels. When clonidine stimulates these receptors, sympathetic output is dialed down, heart rate eases, vessels relax, and blood pressure falls. During steady use, the body adapts to clonidine's constant presence. The sympathetic system is held in check so long that it becomes primed, ready to surge the moment that brake is released. This adaptation is invisible while the drug is present, which is what makes abrupt stopping so dangerous. Pull clonidine away suddenly and the primed sympathetic system floods the body with suppressed signals. Blood pressure can rocket above pre-treatment levels, accompanied by a racing heart, sweating, headache, and agitation, severe enough to risk a stroke. The only safe exit is a gradual provider-guided taper. Only a steady stepwise reduction lets the body relearn its own blood pressure control. Stopping suddenly invites the rebound surge. Doubling the dose before quitting deepens sedation without preventing rebound. Skipping doses on alternating days creates unstable drug levels rather than a smooth descent. Question 8. A nurse is preparing to administer the measles, mumps, and rubella vaccine to a client. The nurse should recognize which of the following conditions is a contraindication. Your options are a mild upper respiratory cold, B. A history of well-controlled asthma, C. Pregnancy, D. A family history of seizures. Got a guess? Lock it in. The correct answer is C, pregnancy. C is correct because the measles, mumps, and rubella vaccine is a live, attenuated vaccine and is contraindicated during pregnancy because the weakened virus poses a risk to the fetus. The nurse should confirm the client is not pregnant first. A is wrong because a common cold and other minor illnesses are not contraindications to immunization. The nurse can safely give the vaccine, since only severe febrile illness or specific allergies warrant delaying it. B is wrong because controlled asthma does not prevent a client from receiving this vaccine. Asthma is a precaution only for the live nasal influenza spray in young children, not a reason to withhold measles, mumps, and rubella. D is wrong because a relative seizure history is not a contraindication here. The relevant concern is the client's own anaphylactic allergy to vaccine components or a current pregnancy, neither of which involves a family seizure disorder. The MMR vaccine is a live attenuated vaccine. It contains real but weakened viruses. Understanding what that means unlocks nearly every safety question about who can and cannot receive it. Because the virus is alive, it replicates just enough inside the body to present the immune system with a realistic target. This mild, controlled infection is what makes live vaccines so powerful. The protection they generate often lasts for decades. The genuine contraindications are narrow. Pregnancy and a severely compromised immune system are real barriers. A minor cold or stable controlled asthma are not. They are distractors that exam writers frequently use to test this exact distinction. The hazard in pregnancy comes from three linked facts. The organism is still living. The developing fetus is exquisitely vulnerable. And the rubella component in particular can cross to the fetus and cause serious birth defects. This is why the MMR is contraindicated in pregnancy. The master distinction is live versus inactivated. Inactivated vaccines carry no living organism and are far safer in pregnancy and immune suppression. Once you can classify a vaccine as live or not live, you can answer almost any question about who should wait and who can safely receive it. Question 9. A nurse is teaching an older adult who takes several medications about polypharmacy. Which of the following statements indicates an understanding of the teaching? Your options are A. Taking more medications lowers my side effects. B. Over-the-counter products do not need reporting. C. I can stop a medication once I improve. D. I should keep a current medication list. Which one is it? Pause the video if you need more time. The correct answer is D. I should keep a current medication list. D is correct because keeping an up-to-date list of all medications, including prescription and over-the-counter products, helps providers spot interactions and prevent duplication. This is a sound strategy for an older adult who is managing polypharmacy and its many risks. A is wrong because taking more medications actually increases the chance of interactions and adverse effects in older adults. Believing that added drugs reduce side effects shows a misunderstanding of the dangers that polypharmacy creates for this client. B is wrong because over-the-counter products can interact with prescriptions and must be reported to the provider. Leaving them off the medication list hides important information. So this statement reflects incorrect understanding of safe practice for polypharmacy. C is wrong because stopping a medication without provider guidance can cause harm or allow a condition to worsen. Discontinuing a drug just because symptoms improve is unsafe and clearly indicates that the teaching was not understood by the client. Polypharmacy means taking several medications at once, a situation that becomes increasingly common as people age and manage multiple chronic conditions. The concern goes beyond counting pills. It is about what happens when those drugs meet inside the same body. Aging changes the body's ability to handle medications. The liver slows its breakdown, The kidneys clear drugs less efficiently, and shifts in body composition mean a normal dose can linger far longer than expected. And when several such drugs stack together, the risk rises faster than the number of drugs alone would suggest. Interactions cause harm in 3 key ways. One drug can raise or lower the blood level of another. 2 drugs can push the same effect until it becomes dangerous. And when a prescriber lacks the complete list, harmful combinations go undetected. A complete medication list must include every prescription, every over-the-counter product, every vitamin, and every herbal remedy. People often omit supplements because they do not consider them real medicine, but they enter the same body and can interact just as powerfully as any prescription drug. Carrying an accurate, current, complete medication list and sharing it at every provider visit is the most protective action a patient can take. It turns multiple partial views into one safe, coordinated whole, and that coordination is what keeps polypharmacy manageable. Question 10. A nurse is caring for a client who is taking allopurinol for chronic gout. Which of the following findings should the nurse identify as an expected therapeutic effect? Your options are A decrease in uric acid levels, B, an increase in blood pressure, C, a rise in blood glucose, D, an increase in heart rate. Take a second. Which answer would you pick? The correct answer is A decrease in uric acid levels. A is correct because allopurinol inhibits uric acid production, so a decrease in uric acid levels is the expected therapeutic effect. The nurse should identify lower uric acid and fewer gout attacks as evidence that the medication is working for the client. B is wrong because allopurinol does not raise blood pressure as a therapeutic effect. Its purpose is to lower the client's uric acid, which reduces gout attacks over time, rather than to change the client's blood pressure. C is wrong because A, rise in blood glucose is not a therapeutic effect of allopurinol. The expected outcome the nurse should identify is decreased uric acid levels in the client being treated for chronic gout with this medication. D is wrong because an increased heart rate is not the goal of allopurinol therapy. The therapeutic effect the nurse should identify is a reduction in uric acid levels for the client who has chronic gout. Allopurinol is a preventive medication used to manage chronic gout by targeting the root cause of the disease, excess uric acid. Understanding how it works means following the path from purines all the way to painful joint crystals. An enzyme called xanthine oxidase runs the final steps that convert purines into uric acid. Allopurinol blocks this enzyme, slowing the production line so that less uric acid enters the bloodstream. When uric acid builds beyond what the blood can hold, it crystallizes inside joints. Those sharp crystals are what trigger the sudden, intense pain and swelling of a gout attack. Allopurinol works slowly over weeks and months. It is taken every day to keep uric acid suppressed, not to stop an attack already in progress. The proof it is working is a measurable, sustained drop in uric acid on blood tests, paired with fewer and milder flares over time. Allopurinol has a single therapeutic mission: lower uric acid. It does not affect blood pressure, blood sugar, or heart rate. Anchoring on that one falling lab value is all you need to confirm the drug is doing its job. Question 11. A nurse is caring for a client who is receiving furosemide. Which of the following findings should the nurse report to the provider as a manifestation of a low potassium level? Your options are A pink tinge to the urine, B, muscle weakness and leg cramps, C, increased salivation, D, constricted pupils. Before I reveal it, which one do you think is right? The correct answer is B, muscle weakness and leg cramps. B is correct because hyperkalemia from furosemide produces muscle weakness, leg cramps, fatigue, and nausea, and it can trigger dangerous dysrhythmias. The nurse should report weakness and cramping, so potassium can be checked and replaced before cardiac effects develop. A is wrong because a pink tinge to urine points toward bleeding. Not a potassium problem. Triamterene, a different diuretic, can turn urine bluish. Low potassium shows itself through muscle and cardiac signs rather than through any change in urine color. C is wrong because increased salivation reflects cholinergic activity and has no link to potassium balance. Hypokalemia instead drains muscle strength and threatens the heart. So weakness and cramps, not extra saliva, are what prompt the nurse to call the provider. D is wrong because constricted pupils stem from drug effects on the eye, not from a falling potassium level. The reportable picture of hypokalemia centers on skeletal muscle complaints and rhythm disturbances, which pupil size does not reflect. Loop diuretics like furosemide are the most powerful diuretics in common use. To understand why they cause potassium loss, we need to look at exactly where and how they act in the kidney. Furosemide acts in the thick ascending limb of the loop of Henle, blocking the NKCC2 transporter that normally reclaims sodium, potassium, and chloride together. Because this segment handles a huge share of filtered salt, blocking it unleashes a powerful surge of urine, hence the term high-ceiling diuretic. Loop diuretics are reserved for states of dangerous fluid overload, heart failure flooding the lungs, severe edema in the legs and belly, and fluid overload in failing kidneys. Their power to pull large volumes quickly makes them the go-to agent when a patient is drowning in retained water. Potassium drops for two reasons at once. The blocked transporter stops potassium from being reclaimed, and the flood of sodium reaching the end of the tubule drives even more potassium out. This double drain is why loop diuretics cause hypokalemia faster and more deeply than the gentler thiazides. Low potassium shows first in muscles and nerves, weakness, leg cramps, and fatigue, but the serious danger is cardiac. Potassium governs heartbeat timing, so hypokalemia can cause palpitations and life-threatening arrhythmias, a risk that rises sharply with digoxin. These symptoms demand prompt reporting, not watchful waiting. Question 12. A nurse is reviewing the health record of a client who has a new prescription for nitrofurantoin. Which of the following findings should the nurse report to the provider as a contraindication? Your options are A. A history of frequent headaches, B. A mild seasonal cough, C. Chronic kidney disease, D. A preference for capsule form. What's your answer? Commit to one before I continue. The correct answer is C. Chronic kidney disease. C is correct because nitrofurantoin depends on adequate kidney function for both effectiveness and safe elimination. Chronic kidney disease increases the risk of toxicity and peripheral neuropathy, so the nurse should report this finding to the provider. A is wrong because frequent headaches are not a contraindication to nitrofurantoin, though headache can occur as a side effect. The important finding to report is impaired kidney function, which makes the drug both less effective and more toxic. B is wrong because a mild seasonal cough is not a contraindication, although the nurse should watch for serious pulmonary reactions during therapy. The condition that contraindicates nitrofurantoin is chronic kidney disease due to impaired excretion. D is wrong because preferring capsules is a formulation choice, not a clinical contraindication. The nurse must instead identify chronic kidney disease because reduced renal clearance leads to drug accumulation and a higher risk of peripheral neuropathy. Nitrofurantoin is a urinary antibiotic with a unique design. The kidneys concentrate it directly into the urine, making it highly effective against urinary tract infections while sparing the rest of the body. The kidney acts as a targeting mechanism, It pulls the drug from the bloodstream and concentrates it in the urine, building levels high enough to kill bacteria right where they live in the bladder. When kidney function is impaired, two problems emerge at once. First, the drug can no longer concentrate in the urine, so it fails to clear the infection. Second, it accumulates in the bloodstream, raising the risk of serious toxicity. Nitrofurantoin that backs up in the blood can damage peripheral nerves, causing numbness, tingling, and weakness, and can injure the lungs. These effects may not fully reverse, which is why chronic kidney disease is a firm contraindication. The key contrast to remember is this: nitrofurantoin depends entirely on the kidney as its ally. Failing kidneys turn a precise, targeted antibiotic into an ineffective and potentially toxic drug. Always pair this medication with normal renal function. Question 13. A nurse notes one client takes hydromorphone and another takes hydroxyzine. The nurse recognizes these as look-alike, sound-alike drugs in order to prevent which of the following? Your options are A. An allergic reaction to both medications. B. A drug-food interaction during meals. C. A delay in the onset of each drug. D. A medication error from name confusion. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. A medication error from name confusion. D is correct because hydromorphone and hydroxyzine appear on the look-alike, sound-alike list because their similar names can lead to one being given in place of the other. Recognizing the similarity helps the nurse prevent a wrong medication error during administration. A is wrong because look-alike, sound-alike awareness targets confusion between drug names, not immune responses. These two medications are not paired because of any shared allergy risk, so preventing an allergic reaction is not the purpose of the list. B is wrong because the concern with these names is mixing up the drugs themselves, not how food affects them. A drug-food interaction is unrelated to the reason this particular pair appears together on the confused name list. C is wrong because onset timing has nothing to do with sound-alike naming. The list exists to stop the wrong drug from being selected and given, not to address how quickly either of these two medications begins to work. Look-alike, sound-alike medications are different drugs whose names are similar enough to be confused, whether spoken aloud, written on a chart, or read quickly from a shelf. The danger lives in the names themselves, not in what the drugs actually do. Mix-ups happen because attention is imperfect, and pharmacy names were never coordinated to be distinct. Names get read in a hurry, heard over background noise, or recalled from memory under pressure, and when two drugs sit side by side on a shelf, the conditions for error are built into everyday care. Consider a strong opioid and an antihistamine whose names begin with the same several letters. One can stop a person's breathing in the wrong amount, the other cannot come close to that. The same opening syllables, wildly different consequences, which is exactly what makes the swap so dangerous. Pharmacies use 4 practical safeguards. Tall man lettering that forces the eye to see the difference. Storing confusable drugs apart rather than side by side. Adding reminders of each drug's purpose. And requiring a second check before any high-risk medicine is given. The key insight is to treat the name itself as a hazard. A deliberate pause. Reading the full label. Confirming the patient and the indication. Is the safety system working exactly as intended? Catching a look-alike before it becomes a harm. Question 14. A nurse is teaching a parent about giving aspirin to a child who has a viral illness. Which of the following statements by the parent indicates an understanding of the teaching? Your options are A. I will avoid aspirin during this illness. B. I will give aspirin to lower the fever. C. I can give aspirin with food. D. I will give a bedtime dose only. Which would you go with? Lock it in before the reveal. The correct answer is A. I will avoid aspirin during this illness. A is correct because aspirin given to a child or adolescent who has a viral illness, such as chickenpox or influenza, can trigger Reyes syndrome. Avoiding aspirin in this setting shows the parent understands the teaching and will protect the child. B is wrong because using aspirin to lower the fever is exactly what must be avoided here, because aspirin during a viral illness can lead to Reyes syndrome. A different antipyretic should be chosen instead, so this statement needs correction. C is wrong because taking aspirin with food protects the stomach, but that does not address the real danger in the situation. The concern in a child who has a viral illness is Reyes syndrome, which food cannot prevent at all. D is wrong because adjusting the timing or size of an aspirin dose does not make it safe for this child. Any aspirin during a viral illness carries the risk of Reyes syndrome, so the medication should be withheld entirely rather than rescheduled. Reyes syndrome is a rare but serious illness in children involving sudden brain swelling and fatty liver damage. Understanding it comes down to one critical drug-disease interaction that changes how we treat fevers in kids. Reyes syndrome follows a recognizable pattern. A child is recovering from influenza or chickenpox. Aspirin is given for the fever, and a crisis of brain swelling and liver failure follows. The association between aspirin and Reyes syndrome was so strong that simply removing aspirin from pediatric care made the disease nearly disappear. At the cellular level, mitochondria, the energy factories inside cells, are thought to be the target. A viral infection already stresses these structures, and salicylate adds a second insult that young. Developing cells cannot handle. The liver, packed with mitochondria, fills with fat and fails, while the brain swells from the same cellular breakdown. The critical contrast is age and context. In adults, aspirin is a trusted workhorse for pain and heart protection, but in a child or teenager fighting a viral illness, the same drug becomes a specific hazard. Age and the presence of a virus flip aspirin from helpful to forbidden. That flip is the heart of the lesson. Aspirin is not universally dangerous, but salicylates must be avoided in any child or teenager with influenza or chickenpox. Parents should read labels carefully since aspirin hides in many combination products. Choosing a non-salicylate fever reducer during viral illness removes the Reyes syndrome risk entirely. Question 15. A nurse is admitting a client who has Addison disease and takes hydrocortisone and is scheduled for surgery. Which of the following actions should the nurse take first? Your options are A. Insert an indwelling urinary catheter. B. Plan to administer a supplemental dose of hydrocortisone. C. Teach coughing and deep breathing exercises. D. Collect a detailed history of the disease. Don't overthink it. Which one feels right? The correct answer is B. Plan to administer a supplemental dose of hydrocortisone. B is correct because the stress of surgery can trigger an acute adrenal crisis in a client with Addison disease, which is life-threatening. The priority is planning a supplemental hydrocortisone dose to prevent this crisis during the added stress. A is wrong because inserting a urinary catheter may be appropriate perioperatively but does not address the immediate life-threatening risk. Preventing adrenal crisis with a steroid dose takes priority over this routine task. C is wrong because teaching coughing and deep breathing is useful but not urgent compared with preventing a crisis. The client's greatest danger is adrenal insufficiency, so the supplemental steroid comes first. D is wrong because collecting a detailed history is helpful but does not protect the client from the surgical stress response. The priority action is the steroid dose, which prevents a potentially fatal adrenal crisis. Cortisol is the body's main stress hormone, and in a healthy person, the adrenal glands automatically surge its production during surgery or serious illness. People with Addison disease have lost that automatic surge entirely. Their glands simply cannot rise to the demand no matter how great the stress. The adrenal cortex is the layer responsible for producing cortisol. In Addison disease, this cortex fails, meaning no cortisol can be released into the bloodstream, not at baseline, and critically, not in response to a surgical stress either. During surgery, a healthy body needs cortisol to support blood pressure, raise blood sugar, and stabilize circulation under strain. Without this surge, a person with Addison disease is left without the hormone their cardiovascular system desperately needs to survive the stress. Without a supplemental dose planned ahead of time, the patient can collapse into an adrenal crisis, dangerously low blood pressure, shock, and possible death. The key principle is anticipation. The crisis is prevented, not just treated. By recognizing that the routine daily dose is inadequate for surgical stress and providing a higher supplemental dose of hydrocortisone before and around the time of surgery. The signal to act is the pairing of chronic steroid replacement with an upcoming physical stress. On an ordinary day, the home dose is enough, but surgery demands far more, and only a deliberate supplemental dose can supply it. That foresight is what keeps a manageable condition from becoming a life-threatening collapse. Question 16. A nurse is caring for a client who has end-stage cancer and is receiving morphine. The family asks why methyl naltrexone was prescribed. Which of the following responses should the nurse make? Your options are: A. It will speed up the breathing. B. It will prevent dependence on morphine. C. It will relieve constipation from the opioid. D. It works with morphine to boost pain relief. Got a guess? Lock it in. The correct answer is C. It will relieve constipation from the opioid. C is correct because methyl naltrexone is an opioid antagonist that relieves severe opioid-induced constipation, unresponsive to laxatives. It blocks opioid receptors in the gut, so the nurse should explain that it treats the client's constipation rather than altering pain control. A is wrong because methyl naltrexone does not increase respirations. It works in the bowel to relieve constipation and does not act on the respiratory drive, so this explanation misstates the purpose of the medication for the family. B is wrong because this medication does not prevent opioid dependence. Its targeted action is on opioid receptors in the gastrointestinal tract to relieve severe constipation, not to change whether the client becomes dependent on morphine. D is wrong because methyl naltrexone does not enhance analgesia. It is given specifically for constipation. Boosting pain relief describes an adjuvant medication, which serves a different role than this opioid antagonist given for bowel function. Opioids are powerful pain relievers, but they create a stubborn problem. They slow the intestines and cause severe, persistent constipation that doesn't fade with time. Methyl naltrexone was designed specifically to solve that problem without touching the pain relief. Methyl naltrexone is chemically built so it cannot cross the blood-brain barrier. It stays in the periphery, blocks opioid receptors in the gut, and lets the intestines resume normal movement, all while the opioid continues working on pain pathways in the brain. Untouched. This is not a general opioid reversal agent and not an ordinary laxative. It does not reverse pain relief, does not trigger withdrawal, and does not simply force the bowel to move. Its only job is to remove the opioid's grip on the gut. The selectivity is the whole point. When you see a patient on strong opioids developing severe constipation and a new bowel agent is added, think methyl naltrexone, targeted relief of opioid-induced constipation while preserving the comfort the opioid provides. Question 17. A nurse is teaching a client who has a new prescription for a benzodiazepine for short-term insomnia. Which of the following instructions should the nurse include? Your options are: A. Avoid alcohol while taking this medication. B. Take the medication with a high-fat meal. C. Double the dose if sleep does not come. D. Drive as usual the morning after a dose. Which one is it? Pause the video if you need more time. The correct answer is A. Avoid alcohol while taking this medication is correct because benzodiazepines depress the central nervous system, and alcohol intensifies this effect, which raises the risk of severe respiratory depression. The nurse should instruct the client to avoid alcohol completely while taking their medication for insomnia. B is wrong because high-fat meals can slow the absorption of some benzodiazepines, but taking the drug with fatty food is not the key teaching point. The critical instruction is to avoid alcohol, not to pair the dose with a fatty meal. C is wrong because doubling the dose can cause dangerous oversedation and respiratory depression in the client. Clients should take only the prescribed amount, so increasing the dose on their own when sleep is slow to come is unsafe guidance. D is wrong because benzodiazepines can cause lingering drowsiness and impaired coordination into the next day. The client should avoid driving until the sedating effects fully wear off, so driving as usual the next morning could be hazardous. Benzodiazepines are sedative medications that work by boosting GABA, the brain's natural braking signal, to reduce anxiety, relax muscles, and bring on sleep. Understanding how they work is the key to understanding why one combination makes them dangerous. At the synapse, benzodiazepines bind to a site next to the GABA receptor, amplifying its inhibitory signal. This enhanced chloride flow is what slows nerve firing. It is the same mechanism that makes these drugs effective, and that creates the hazard when combined with other depressants. By turning up the brain's braking signal, a benzodiazepine produces 3 clinically useful effects. It induces sleep, reduces anxiety, and relaxes muscles. These effects make it a fast, reliable short-term remedy, but they also mean the drug is actively depressing the central nervous system. The danger is called additive depression. Benzodiazepines and alcohol both slow the central nervous system through overlapping pathways. So when taken together, their depressant effects compound rather than simply add. Even modest amounts of each can overwhelm the brainstem's control of breathing and consciousness, producing profound sedation, respiratory failure, and death. The dose of each alone may seem modest, but the combination can suppress breathing during sleep, the very time the drug is meant to help. The same warning extends to opioids and any other CNS depressant. Avoiding the combination entirely is what keeps a routine prescription safe. Question 18. A nurse is caring for a client who is taking gemfibrozil. Which of the following findings should the nurse report to the provider as a possible adverse effect of this medication? Your options are A craving for sweet foods, B, increased energy in the morning, C, a decrease in appetite, D, right upper abdominal pain and bloating. Take a second. Which answer would you pick? The correct answer is D, right upper abdominal pain and bloating. D is correct because gemfibrozil increases the risk of gallstones. The nurse should report right upper abdominal pain and bloating, which can indicate gallbladder disease, so the provider can evaluate the client for this complication of fibrate therapy. A is wrong because a craving for sweets is not a recognized effect of gemfibrozil and does not signal a complication. The finding that warrants reporting is right upper quadrant pain with bloating, which can point to the gallstones this drug may cause. B is wrong because increased morning energy is not an adverse effect and would not be reported as a concern. The nurse instead watches for right upper abdominal pain and bloating, signs that may reveal gallbladder disease linked to fibrate use. C is wrong because A, decreased appetite is vague and not specific to gemfibrozil's main risks. The reportable problem here is gallbladder pain under the right ribs, which suggests the stones this fibrate can promote. Gemfibrozil belongs to a drug class called fibrates, prescribed specifically to lower high triglycerides in the blood. Unlike statins, fibrates fill a unique niche, but in changing how the body handles fats, they introduce risks in an unexpected organ, the gallbladder. Triglycerides at high levels are dangerous. They raise the risk of heart disease and can inflame the pancreas. Fibrates work by pushing the body to metabolize and clear triglycerides more efficiently, which is exactly why statins alone aren't sufficient for this job. Fibrates cause the liver to push excess cholesterol into bile. When bile becomes oversaturated with cholesterol, it begins to crystallize, forming hard gallstones that can lodge in the gallbladder or its ducts. The classic warning signs are right upper quadrant abdominal pain, bloating, nausea, and discomfort after fatty meals, all pointing to the gallbladder. These symptoms in a patient on gemfibrozil should never be dismissed as simple indigestion. Gemfibrozil lowers triglycerides as intended, but its risks live elsewhere, in the gallbladder and in muscle tissue. Monitoring right upper abdominal symptoms, not just lipid values, is essential for safe use of this drug. Question 19. A nurse is caring for a client who takes acarbose for type 2 diabetes and develops hypoglycemia. Which of the following should the nurse use to treat the low blood sugar? Your options are A. Table sugar dissolved in water, B. Glucose tablets, C. A glass of milk with honey, D. A spoonful of granulated sucrose. Before I reveal it, which one do you think is right? The correct answer is B. Glucose tablets. B is correct because acarbose blocks the breakdown of sucrose in the gut, so table sugar will not raise blood glucose effectively. The nurse treats hypoglycemia with glucose itself, such as glucose tablets, which does not require that enzyme. A is wrong because table sugar is sucrose, which acarbose prevents the body from breaking down into absorbable glucose. Dissolving it in water does not bypass the block, so it fails to correct the low blood sugar quickly. C is wrong because milk with honey relies partly on sucrose and lactose, whose breakdown acarbose impairs. This choice would act too slowly, so it is less reliable than pure glucose for a client taking acarbose. D is wrong because granulated sucrose is exactly the sugar acarbose blocks from being digested. Giving sucrose to an acarbose-treated client will not raise glucose promptly, which is why glucose is the correct treatment. Acarbose is an alpha-glucosidase inhibitor. It works by blocking enzymes in the small intestine that break down complex carbohydrates and table sugar into simple glucose. This slows carbohydrate absorption and blunts the sharp blood sugar spike that follows a meal. Normally, alpha-glucosidase enzymes on the intestinal lining split sucrose and other sugars into absorbable glucose. Acarbose sits in the enzyme's active site and blocks that split, so the sugar stays in the gut, unabsorbed, and blood glucose rises more gradually after eating. Here is the trap. If a patient on acarbose develops hypoglycemia and reaches for table sugar, the drug blocks the very enzyme needed to split that sucrose into glucose. The sugar sits undigested in the gut, while blood glucose stays dangerously low. The correct rescue is pure glucose, tablets or gel. Glucose is a simple sugar that requires no enzymatic breakdown whatsoever, so it is absorbed directly through the intestinal wall even while acarbose is active. This is the one situation where grabbing any sugary food is the wrong instinct. For most hypoglycemic patients, any fast sugar will do, but acarbose disables the enzyme that converts sucrose into glucose. Recognizing the drug class, alpha-glucosidase inhibitor points directly to glucose tablets as the only reliable rescue. Question 20. A nurse is caring for a client who received spinal anesthesia and has not voided several hours after the procedure. Which of the following actions should the nurse take? Your options are A. Restrict the client's fluids immediately. B. Reassure the client that voiding is optional. C. Notify the provider about the lack of voiding. D. Encourage the client to ambulate alone. What's your answer? Commit to one before I continue. The correct answer is C. Notify the provider about the lack of voiding. C is correct because spinal anesthesia can cause urinary retention, so the nurse should notify the provider when the client has not voided within the expected time. Monitoring output and reporting retention protects the client from bladder complications after the procedure. A is wrong because restricting fluids does not resolve urinary retention and could worsen the client's status. The appropriate action for the nurse is to notify the provider about the client's failure to void after the spinal anesthesia. B is wrong because reassuring the client that voiding is optional ignores the retention that can follow spinal anesthesia. The nurse should report the lack of voiding to the provider rather than treat it as an acceptable finding for the client. D is wrong because encouraging the client to ambulate alone is unsafe after spinal anesthesia, when leg strength must be confirmed first. The safer step is to report the client's inability to void so the provider can intervene. Spinal anesthesia numbs the lower half of the body by delivering anesthetic into the fluid-filled space surrounding the spinal cord. It blocks sensory, motor, and autonomic nerves all at once. And that last category is what creates a hidden danger after surgery. The injection enters the subarachnoid space where it bathes the nerve roots leaving the cord. Because the block does not discriminate, it silences sensory nerves, motor nerves, and the autonomic nerves that control organs like the bladder simultaneously. 3 nerve types are blocked together: sensory nerves that carry pain and touch, motor nerves that drive movement, and autonomic nerves that run involuntary organ functions, including the conversation between the bladder and the brain. Without autonomic signaling, the bladder fills but never sends the urge to void, and the muscle responsible for emptying it is temporarily out of service. The silent accumulation, called urinary retention, can stretch the bladder to a harmful degree before anyone realizes there is a problem. After spinal anesthesia, the absence of urge is expected, not reassuring. The nurse must actively monitor time since last void, scan for bladder fullness, and notify the provider promptly so a catheter can relieve retention before injury occurs. Question 21. A nurse is teaching a client who has a new prescription for glipizide for type 2 diabetes. Which of the following instructions about timing should the nurse include? Your options are A. Take it about 30 minutes before breakfast. B. Take it 2 hours after lunch. C. Take it at bedtime each night. D. Take it only when your blood sugar is high. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Take it about 30 minutes before breakfast. A is correct because glipizide stimulates insulin release, so it is taken about 30 minutes before breakfast to match insulin with the meal. The nurse also teaches the client to withhold the dose if a meal will be missed. B is wrong because taking glipizide 2 hours after lunch separates the drug from the meal it should support. This timing misses the goal of having insulin available as food is digested. C is wrong because a bedtime schedule does not align glipizide with food, raising the risk of low blood sugar overnight. The drug should precede the morning meal, so a nighttime dose is incorrect timing. D is wrong because glipizide is taken on a regular schedule before a meal, not only when glucose is high. Using it as a reactive dose ignores how the medication is meant to control blood sugar. Glipizide belongs to a drug class called sulfonylureas, which lower blood sugar by triggering the pancreas to release insulin. Understanding how this mechanism works explains exactly why timing the dose to a meal is so critical. Sulfonylureas act directly on the insulin-producing beta cells of the pancreas, forcing them to release a surge of insulin. This release happens whether or not food is on the way, which is what makes timing so important. Glipizide is taken roughly 30 minutes before breakfast so that the insulin it releases peaks at the same time glucose from the meal enters the bloodstream. The drug and the meal must arrive together. They are partners. If the dose is taken and the meal is skipped or delayed, insulin surges into the blood with no glucose to act on. Blood sugar plunges, causing hypoglycemia, shakiness, sweating, and confusion. This is the signature danger of the entire sulfonylurea class. Unlike metformin, which is taken with food mainly to avoid stomach upset, sulfonylureas actively drive insulin release and must be paired with a meal to prevent a dangerous low. Matching the drug's mechanism to its timing is the heart of using glipizide safely. Question 22. A nurse is caring for a client who has received doxorubicin for several months. Which of the following findings should the nurse report to the provider as a sign of delayed cardiac toxicity? Your options are A. Reddish-colored sweat, B. Mild hair thinning, C. A sore mouth, D. Shortness of breath. Which would you go with? Lock it in before the reveal. The correct answer is D. Shortness of breath. D is correct because doxorubicin can cause delayed cardiomyopathy leading to heart failure months to years after treatment. Shortness of breath may signal this cardiac toxicity, so the nurse should report it for further cardiac evaluation. A is wrong because reddish sweat is a harmless expected effect of doxorubicin and requires no action. It reflects the drug's pigment, not heart damage, so it should not be confused with the dyspnea that warns of cardiac toxicity. B is wrong because hair thinning is an anticipated effect of many cytotoxic agents and is not a cardiac warning. The finding signaling delayed heart toxicity is breathing difficulty, which reflects a failing heart rather than follicle damage. C is wrong because a sore mouth reflects mucositis from chemotherapy affecting the lining of the digestive tract. While it needs supportive care, it does not indicate the cardiomyopathy that shortness of breath would suggest after doxorubicin therapy. Doxorubicin is an anthracycline chemotherapy drug that's broadly effective against hard-to-treat cancers, but it carries a serious, lasting risk to the heart. Understanding why requires looking at what it does inside heart muscle cells. Inside heart muscle cells, doxorubicin generates harmful free radicals. These reactive molecules attack the contractile machinery the heart depends on. The damage accumulates with every dose, which is why there is a ceiling on the total lifetime amount a patient can receive. 3 features make this toxicity easy to miss. First, it has a delayed onset. Symptoms may not appear until months or years after treatment ends. Second, risk rises with cumulative dose over the entire course of therapy. Third, the result is cardiomyopathy. The weakened heart progressively loses its ability to pump, which can advance to heart failure. When the damaged heart begins to fail, it announces itself with the classic signs of a failing pump: shortness of breath, especially on exertion or lying flat, fatigue, swelling in the legs, and a cough. In anyone who has received doxorubicin, these symptoms demand prompt evaluation of heart function. Here's the key contrast. Doxorubicin famously turns urine red, which frightens patients but is completely harmless. The real danger is the opposite: quiet, delayed, and potentially fatal. Learning to dismiss the red urine and recognize the breathlessness is exactly the clinical discrimination this drug demands. Question 23. A nurse is teaching a client who has a new prescription for psyllium, a bulk-forming laxative. Which of the following instructions should the nurse include? Your options are A. Take this medication only at bedtime. B. Restrict your fluid intake while taking this. C. Take each dose with a full glass of water. D. Expect this to work within a few minutes. Don't overthink it. Which one feels right? The correct answer is C. Take each dose with a full glass of water. C is correct because psyllium absorbs water to soften and add bulk to stool. Taking it with a full glass of water lets it pass safely and prevents it from swelling and blocking the esophagus or intestine, which is the main safety concern. A is wrong because bulk-forming laxatives are not tied to a bedtime-only schedule and act over a day or more. Restricting the dose to bedtime offers no benefit and ignores the key point about taking it with adequate water. B is wrong because limiting fluids while taking a bulk-forming laxative is dangerous, because the product needs water to move through the gut. Restricting fluid raises the risk of obstruction rather than supporting the laxative effect. D is wrong because bulk-forming laxatives work gradually, not within minutes. Expecting an immediate result fits a rectal stimulant instead. So this sets up a false expectation about how psyllium relieves constipation. Psyllium is a bulk-forming laxative, a soluble fiber that relieves constipation by restoring the physical bulk that stool needs to move forward. Understanding how it works explains why how you take it is just as important as taking it at all. Once swallowed with adequate fluid, psyllium soaks up water and swells into a soft, bulky gel. That gel stretches the intestinal wall, and that stretch triggers the natural muscular waves, peristalsis, that push stool forward, producing a normal, formed bowel movement. Psyllium works differently from other laxative classes. Stimulant laxatives irritate the bowel into action. Osmotic ones draw water in chemically. Psyllium simply adds physical bulk, a gentler, more natural mechanism. The safety risk is the flip side of the mechanism. Without enough water, psyllium begins to thicken before it reaches the stomach, creating a sticky mass that can cause choking or intestinal blockage. The rule is simple. Always take each dose with a full glass of water and maintain fluid intake throughout the day. Question 24. A nurse is caring for a client who is receiving a local anesthetic combined with epinephrine. The nurse should recognize this combination as contraindicated for use in which of the following areas? Your options are A. The thigh, B. The fingers, C. The upper arm, D. The abdomen. Got a guess? Lock it in. The correct answer is B. The fingers. B is correct because epinephrine added to a local anesthetic is contraindicated in areas with end arteries, such as the fingers, because vasoconstriction can cause gangrene. The nurse should recognize the fingers as an unsafe site for this combination in the client. A is wrong because the thigh is not an end artery site, so a local anesthetic with epinephrine can be used there. The contraindicated area the nurse should recognize is the fingers, because of the risk of gangrene from vasoconstriction. C is wrong because the upper arm has adequate circulation and is not an end artery region. Epinephrine with a local anesthetic is avoided in the fingers rather than the upper arm, because end arteries supply the digits. D is wrong because the abdomen has rich collateral circulation and does not carry the gangrene risk seen in the digits. The contraindicated location is the fingers, where vasoconstriction could choke off the only blood supply. Local anesthetics are often combined with epinephrine to extend their effect. Epinephrine is a vasoconstrictor. It tightens blood vessels, slowing the washout of the anesthetic and keeping the surgical field drier. In most of the body, this pairing is routine and safe. The benefits are real. The anesthetic lingers longer, fewer repeat injections are needed, and blood loss at the site is reduced. This works safely in well-supplied tissues because neighboring vessels keep the tissue perfused, even when some are squeezed shut. The danger emerges in end artery sites, fingers, toes, the nose tip, ears, and penis, where a single narrow vessel does all the work. When epinephrine clamps that vessel shut, there is no alternate route. Oxygen delivery falls and tissue can become ischemic. These locations share one critical feature: little or no backup circulation. Prolonged vasoconstriction here can lead to ischemia and, in the worst case, gangrene, potentially costing a patient a digit. Plain anesthetic without epinephrine is used at these sites instead. The takeaway is the contrast. The same vasoconstriction that helps in a forearm can kill tissue in a fingertip. Richly supplied areas tolerate brief tightening. End artery sites do not. Recognizing an end artery location is the key to catching this contraindication. Question 25. A nurse is caring for a client who has myasthenia gravis and takes neostigmine. The client develops increased weakness with drooling, watery eyes, and abdominal cramping. Which of the following should the nurse suspect? Your options are: A. Cholinergic crisis from excess medication. B. Worsening disease requiring a higher dose. C. An allergic reaction to the medication. D. Reduced absorption of the medication. Which one is it? Pause the video if you need more time. The correct answer is A. Cholinergic crisis from excess medication. A is correct because muscle weakness combined with heavy cholinergic signs such as drooling, tearing, and cramping indicates a cholinergic crisis from too much neostigmine. The nurse should withhold the next dose and notify the provider promptly about these findings. B is wrong because a myasthenic crisis from too little drug also causes weakness, but it would not flood the client with saliva, tears, and abdominal cramps. Those extra secretions are what distinguish a cholinergic overdose from undertreatment here. C is wrong because an allergic reaction would more likely bring rash, swelling, or breathing difficulty rather than heavy secretions. A picture dominated by drooling, tearing, and abdominal cramping points to cholinergic excess instead of a hypersensitivity reaction. D is wrong because poor absorption would simply let the client's weakness return without any added secretions. The drooling and abdominal cramping show that the drug is very much active in the body, not failing to reach the system. Myasthenia gravis weakens muscles because the immune system destroys acetylcholine receptors at the neuromuscular junction. Neostigmine treats this by blocking acetylcholine esterase, the enzyme that breaks down acetylcholine, so more messenger stays available to stimulate those damaged receptors. Normally acetylcholinesterase clears acetylcholine quickly. Neostigmine inhibits that enzyme, letting acetylcholine linger and repeatedly bind the remaining receptors, restoring some muscle strength. When neostigmine pushes acetylcholine too high, the entire parasympathetic nervous system is overstimulated. The result is a flood of secretions, drooling, tearing, and sweating, along with abdominal cramping, bradycardia, and paradoxically, muscle weakness returns as receptors become overwhelmed. The critical exam insight is that both too much and too little medication cause muscle weakness. Weakness paired with secretions, drooling, tearing, cramping, signals a cholinergic crisis from excess drug. Weakness without those signs points to undertreatment. The autonomic signs are the tiebreaker. When you see neostigmine, myasthenia gravis, and new weakness together, look for secretory signs. Their presence means stop the drug, not add more. Missing that distinction is how a well-meaning dose deepens a crisis. Question 26. A nurse is teaching a client who has a new prescription for oral penicillin V. Which of the following instructions should the nurse include about taking the medication? Your options are: A. Crush the tablet into juice daily. B. Take it only when symptoms flare. C. Double the dose if one is missed. D. Take each dose with a meal. Take a second. Which answer would you pick? The correct answer is D. Take each dose with a meal. D is correct because penicillin V, amoxicillin, and amoxicillin clavulanate can be taken with meals, which improves tolerance. The nurse should instruct the client to take these particular penicillins with food while completing the full prescribed course. A is wrong because routinely crushing the tablet is not a required instruction and is not the key teaching point. The relevant guidance for penicillin V is that it may be taken with meals and that the full course must be completed. B is wrong because taking the drug only during symptom flares undermines therapy and promotes resistance. Antibiotics must be taken on schedule for the entire course, and penicillin V specifically may be administered with food for comfort. C is wrong because doubling up after a missed dose can cause adverse effects and is not advised. The correct teaching focuses on taking penicillin 5 with meals and finishing the complete course rather than altering doses independently. Penicillin V is an oral antibiotic used for infections like strep throat. What makes it special is a single chemical property. It resists destruction by stomach acid, which changes how patients are told to take it. Penicillins work by wrecking the bacterial cell wall, the structural layer bacteria need to survive. For that to happen, enough drug must be absorbed from the gut and reach the bloodstream and the infection site. Acid-sensitive penicillins can be disrupted by food and stomach acid, so an empty stomach is required. Penicillin V is built differently. Food does not weaken it, so food is a friend rather than a foe. Because penicillin V resists stomach acid, taking it with a meal costs nothing in effectiveness. The meal cushions the stomach, reducing nausea that tempts patients to quit early. And better adherence means completing the full course, which prevents resistant bacteria from rebounding. The practical takeaway is this: penicillin V's acid stability lets each dose ride along with a meal to ease side effects and build a routine. Finishing the full prescription, not just feeling better, is what clears the infection and prevents resistance. Question 27. A nurse is teaching a client who takes a bile acid sequestrant and digoxin. Which of the following instructions should the nurse include about taking these medications? Your options are: A. Take both medications at the same time. B. Crush the digoxin and mix it with the sequestrant. C. Separate the digoxin from the sequestrant by several hours. D. Stop the digoxin while taking the sequestrant. Before I reveal it, which one do you think is right? The correct answer is C. Separate the digoxin from the sequestrant by several hours. C is correct because bile acid sequestrants bind other drugs including digoxin and reduce their absorption. The nurse should instruct the client to take digoxin separated from the sequestrant by several hours so the digoxin can be absorbed and remain effective. A is wrong because taking both together lets the sequestrant bind the digoxin in the gut, lowering how much is absorbed. To preserve the digoxin's effect, the doses must be spaced apart rather than swallowed at the same time. B is wrong because crushing digoxin into the sequestrant would maximize binding and waste the dose, the opposite of what is needed. The correct approach is to separate the two medications by several hours so the digoxin is properly absorbed. D is wrong because stopping digoxin is not appropriate and could worsen the client's heart condition. The safe solution is to keep taking both drugs but space them several hours apart so the sequestrant does not block digoxin absorption. Bile acid sequestrants lower cholesterol by trapping bile acids in the gut, forcing the liver to pull cholesterol from the blood to make more. But the mechanism that makes them useful also creates a physical drug interaction worth understanding. Inside the intestine, the sequestrant is a large sticky molecule. It latches onto bile acids and carries them out in the stool. Because it never enters the bloodstream, it avoids systemic exposure, but anything else in the gut is at risk of being grabbed too. The interaction is purely physical, not chemical. If another drug, like digoxin, is in the intestine at the same time as the sequestrant can latch onto it. The trapped drug is carried out in the stool before it ever reaches the bloodstream. Because binding only happens when both drugs share the gut at the same moment, the solution is simple timing. Digoxin and other vulnerable drugs, including fat-soluble vitamins, should be taken well before or several hours after the sequestrant, so each is absorbed independently. The sequestrant doesn't chemically alter other drugs, it just traps them physically. Spacing doses keeps each drug free to do its job, and that timing principle applies to digoxin, vitamins, and any other medication a patient takes alongside a sequestrant. Question 28. A nurse is caring for a client who has preeclampsia and is receiving magnesium sulfate IV. Which of the following findings should the nurse report to the provider? Your options are A. Present deep tendon reflexes. B. A drop in urine output. C. Mild pedal edema. D. A calm, restful state. What's your answer? Commit to one before I continue. The correct answer is B. A drop in urine output. B is correct because a drop in urine output is associated with magnesium sulfate toxicity, because reduced output can allow magnesium to accumulate. The nurse should report this finding and prepare to discontinue the infusion if toxicity in the client is confirmed. A is wrong because present deep tendon reflexes are a reassuring finding, whereas their loss would signal toxicity. Intact reflexes, therefore, do not need to be reported the way a falling urine output does in the client receiving magnesium sulfate. C is wrong because mild pedal edema is expected in preeclampsia and is not a sign of magnesium toxicity. The reportable warning for the nurse is a decrease in urine output, which can allow magnesium to build up in the client. D is wrong because a calm, restful state is acceptable, whereas magnesium toxicity brings depressed respirations and absent reflexes. A drop in urine output, not restfulness, is the finding the nurse should report to the provider for this client. Magnesium sulfate is used in preeclampsia to prevent eclamptic seizures. It works by calming overexcitable nerves and muscles, raising the threshold at which a seizure can fire. Understanding why it works also explains exactly how it becomes dangerous. Magnesium sits on a narrow continuum. At the therapeutic level, it quiets irritable nerves just enough to block seizures. Push the level higher and that same quieting silences deep tendon reflexes, weakens muscles, slows breathing, and can depress the heart. Toxicity is progressive. The first warning is loss of deep tendon reflexes, followed by respiratory depression, and finally cardiac slowing. Recognizing this sequence early is essential because it gives time to act before breathing is threatened. Magnesium leaves the body almost entirely through the kidneys, so urine output is the safety margin. When output falls, clearance drops and the drug accumulates even at a steady infusion rate. A falling urine output is therefore an early warning that must be reported promptly before reflexes vanish and breathing is compromised. The therapeutic and toxic effects of magnesium lie on the same continuum. Monitoring reflexes, breathing rate, and urine output together tracks the patient's safety, and a drop in urine output is the earliest signal that the margin is closing. Question 29. A nurse is preparing to administer tetracycline and reviews the client's history. The nurse should recognize which of the following conditions is a contraindication. Your options are A. Pregnancy, B. Mild controlled high blood pressure, C. A history of seasonal allergies. D. A preference for evening dosing. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Pregnancy. A is correct because tetracyclines are contraindicated in pregnancy because they can stain developing teeth and affect fetal bone growth. The nurse should recognize pregnancy as a reason to withhold the drug and consult the provider about an alternative. B is wrong because well-controlled hypertension is not a contraindication to tetracycline. The condition the nurse must identify is pregnancy. Since tetracyclines pose a risk to fetal teeth and bone that blood pressure status does not. C is wrong because seasonal allergies do not contraindicate tetracycline therapy. The significant concern is pregnancy because the drug crosses the placenta and discolors developing teeth, whereas ordinary environmental allergies do not affect its safety. D is wrong because preferring evening dosing is a scheduling matter, not a contraindication, though bedtime dosing should be avoided to reduce esophageal irritation. The true contraindication here is pregnancy because of harm to fetal development. Tetracycline is a broad-spectrum antibiotic, but it carries a firm contraindication in pregnancy and young children. The reason is chemical. Tetracycline binds tightly to calcium, and calcium is exactly what developing teeth and bones are made of. In a developing fetus or young child, tetracycline crosses the placenta or enters the bloodstream and binds directly into the calcium of forming teeth and bones. The result is permanent yellow-grey-brown discoloration built into the tooth itself, not a surface stain, but part of the structure. 3 permanent consequences can follow: tooth discoloration, weakened enamel, and slowed bone growth. These harms occur only where new tissue is actively forming, which is why the danger zones are fetal development and early childhood. The same calcium affinity drives 2 distinct problems. In a developing body, the binding deposits drug into tissue, a teratogenic harm. In the adult gut, the same binding can block the drug's own absorption when taken with dairy. 1 affinity, 2 very different consequences. The clinical signal is straightforward. Whenever you see tetracycline paired with pregnancy, breastfeeding, or a young child, that pairing is the contraindication. The drug is avoided to protect developing calcium tissue, teeth and bones that are still being built. Question 30. A nurse is caring for 2 clients who have peptic ulcer disease. One takes aluminum hydroxide and one takes magnesium hydroxide as antacids. Which of the following findings should the nurse expect from the magnesium product? Your options are A. Constipation, B. Hypertension, C. A slow heart rate, D. Diarrhea. Which would you go with? Lock it in before the reveal. The correct answer is D. Diarrhea. D is correct because magnesium-based antacids tend to cause diarrhea, while aluminum and calcium products cause constipation. Knowing this difference lets the nurse anticipate loose stools from the magnesium product and alternate compounds to normalize bowel function. A is wrong because constipation is a signature bowel effect of aluminum and calcium antacids, not magnesium. This option assigns the opposite product's effect, which is the classic distinction the question is testing. B is wrong because antacids are not expected to raise blood pressure as a routine effect of the magnesium ingredient. Sodium-containing antacids can promote fluid retention, but that is a separate issue from the bowel effect asked about here. C is wrong because a slow heart rate is not a typical antacid effect tied to magnesium products at usual doses. The expected and most distinguishing finding for this compound is its effect on the bowel, specifically loose stools. Antacids work by neutralizing excess stomach acid, bringing quick relief from heartburn and peptic ulcer pain. but the metal at the core of each antacid does more than neutralize acid. It also determines what happens further down the digestive tract. The neutralization itself is simple chemistry. A base meets acid in the stomach, raising the pH and easing irritation of the stomach lining. This mechanism is shared across all antacids, regardless of which metal they contain. The key distinction is the metal. Magnesium pulls water into the bowel and speeds transit, causing diarrhea. Aluminum slows the bowel and firms the stool, causing constipation. Calcium behaves similarly to aluminum, also tending toward constipation. Because magnesium loosens and aluminum tightens, many antacid products combine the two metals. The opposing effects partly cancel each other out, leaving bowel function closer to normal. Knowing the metal immediately predicts the expected side effect and explains why combination products exist. Question 31. A nurse is caring for a client who has generalized anxiety disorder and is receiving alprazolam. Which of the following findings should the nurse identify as an expected therapeutic effect? Your options are A. Increased alertness and energy. B. A reduction in feelings of anxiety. C. Elevated blood pressure. D. Improved muscle strength. Don't overthink it. Which one feels right? The correct answer is B. A reduction in feelings of anxiety. B is correct because alprazolam is a benzodiazepine that enhances the inhibitory effects of GABA in the central nervous system, producing rapid relief of anxiety. A decrease in the client's anxious feelings is the expected therapeutic response the nurse should observe. A is wrong because benzodiazepines depress the central nervous system and cause sedation, not heightened alertness. Increased energy runs counter to the calming, drowsy effect that alprazolam typically produces. So it is not an expected therapeutic finding. C is wrong because alprazolam does not raise blood pressure as a therapeutic goal. Its purpose is to relieve anxiety through central nervous system depression, so an elevated blood pressure would not be an expected effect of treatment with this drug. D is wrong because improving muscle strength is not an action of this medication. Although benzodiazepines can relax skeletal muscles, the therapeutic aim in anxiety is relief of symptoms, not an increase in the client's muscle strength. Alprazolam is a benzodiazepine designed to quiet an overactive, fearful nervous system. Understanding what it is actually supposed to do and what counts as proof it is working is the core clinical skill here. The mechanism works by amplifying the brain's own calming system. GABA is the nervous system's built-in brake, and alprazolam binds to the GABA-A receptor and strengthens its effect, pressing that brake harder so overactive, worry-driven circuits slow down. The therapeutic goal is a genuine reduction in anxious feelings, calmer mood and less worry. Sedation and drowsiness ride along as side effects to be managed, and long-term use carries a risk of dependence. None of those secondary effects are the target. GAD is not ordinary stress. It is relentless. Hard to control worry accompanied by restlessness, tension, and dread, because the distress can be severe enough to derail daily life. A fast-acting drug like alprazolam is chosen when relief cannot wait. A clinician judging whether alprazolam is working looks for calmer mood and less worry, not for sleepiness. Relief of anxiety is the purpose. Sedation and dependence are the costs. Keeping that distinction clear is what sound pharmacology looks like in practice. Question 32. A nurse is teaching a client who uses a transdermal nitroglycerin patch for chronic angina. Which of the following statements by the client indicates an understanding of the teaching? Your options are A. I will cut the patch to adjust my dose. B. I will leave the patch on day and night. C. I will remove the patch for several hours daily. D. I will place the patch on the same spot. Got a guess? Lock it in. The correct answer is C. I will remove the patch for several hours daily. C is correct because a daily nitrate-free interval prevents tolerance to nitroglycerin. Removing the patch for part of each day shows the client understands how to keep the medication effective and avoid losing its ability to prevent anginal attacks. A is wrong because cutting a transdermal patch can release the drug unevenly and deliver an unreliable dose, so it is never advised. The statement that reflects correct understanding is allowing a patch-free period each day to prevent tolerance. B is wrong because wearing the patch continuously day and night leads to tolerance, blunting the drug's effect over time. The client demonstrates understanding by removing it for several hours daily, which is the opposite of leaving it on around the clock. D is wrong because applying the patch to the same site repeatedly can irritate the skin, so sites should be rotated. More importantly, the teaching point that prevents tolerance is the daily drug-free interval, not where the patch is placed. Transdermal nitroglycerin patches are designed for the long-term prevention of chronic angina, keeping blood vessels relaxed so ordinary activity doesn't trigger chest pain. But continuous nitrate delivery creates a hidden problem that every patient and clinician needs to understand. Nitroglycerin is a nitrate that acts on smooth muscle in vessel walls, causing them to relax and widen. This vasodilation reduces the resistance the heart must pump against, easing its workload and improving blood flow to the heart muscle. When nitrate levels never drop, the blood vessels gradually stop responding, a process called tolerance. The pathways the drug acts through become desensitized, so the same dose produces less and less effect. Within a day of uninterrupted exposure, the patch can lose much of its protective power. The fix is deliberate and counterintuitive. Remove the patch for several hours each day, typically overnight when angina risk is lowest. This nitrate-free interval allows the vessels to reset and regain sensitivity. So when the next patch goes on in the morning, the drug works as intended. It's worth contrasting the two forms of nitroglycerin. The patch provides steady, long-term prevention and must be cycled off daily to stay effective. A sublingual tablet of the same drug is used only to stop an attack already underway. It's never worn continuously, so tolerance is never an issue. Question 33. A nurse is caring for a client who has rheumatoid arthritis and a new prescription for methotrexate. The nurse should monitor the client for which of the following as an early manifestation of toxicity? Your options are mouth ulcers, B. Improved appetite, C. Weight gain, D. Increased energy. Which one is it? Pause the video if you need more time. The correct answer is A. Mouth ulcers. A is correct because ulcerations in the mouth and throat are often the first manifestation of methotrexate toxicity. The nurse should inspect the client's mouth daily and stop the medication and notify the provider if these ulcers appear during therapy. B is wrong because improved appetite is not a sign of methotrexate toxicity. Toxicity instead presents early with mouth ulcers, and clients may experience anorexia rather than an increased desire to eat while taking the medication for arthritis. C is wrong because weight gain does not indicate methotrexate toxicity. The earliest warning the nurse should watch for is ulcerative stomatitis, which is found by inspecting the client's mouth, gums, and throat each day. D is wrong because increased energy is unrelated to methotrexate toxicity. The defining early finding is mouth and throat ulceration, which signals the need to hold the drug and notify the provider for the client's safety. Methotrexate works by blocking the enzyme that activates folate, starving rapidly dividing cells of what they need to copy DNA. Understanding why certain tissues suffer first explains the drug's side effects and why early signs matter so much. When folate is blocked, the cells that divide fastest are hit hardest, They need a constant fresh supply to keep up their turnover. Slow dividing tissues like muscle and nerve are largely spared. The mouth lining and gut lining renew themselves constantly, shedding and replacing cells every day. The bone marrow is equally active, producing blood cells non-stop. These are the tissues methotrexate hits first. Stomatitis, painful mouth ulcers and inflammation is often the very first sign of methotrexate toxicity. Because the mouth lining is among the fastest renewing tissues, it breaks down before the bone marrow does. Catching these sores early allows a dose adjustment or folic acid reinforcement before blood counts fall. Mouth sores in a patient on methotrexate are a predictable, early footprint of the drug's mechanism, not a coincidence. They are the canary warning that more dangerous marrow toxicity may follow if nothing is done. Question 34. A nurse is preparing to mix regular insulin and NPH insulin in one syringe for a client. Which of the following actions should the nurse take? Your options are: A. Draw the two insulins in any order. B. Draw up the NPH insulin first, then the regular. C. Shake both vials vigorously before drawing. D. Draw up the regular insulin first, then the NPH. Take a second. Which answer would you pick? The correct answer is D. Draw up the regular insulin first, then the NPH. D is correct because when mixing, the nurse draws the clear regular insulin into the syringe first, then the cloudy NPH. This clear before cloudy order prevents contaminating the regular insulin vial with the longer acting insulin. A is wrong because order matters when mixing insulins, so drawing them in any sequence is unsafe. The clear before cloudy rule exists specifically to protect the regular insulin vial from being contaminated by the longer acting cloudy insulin. B is wrong because drawing the NPH first risks carrying cloudy, longer acting insulin back into the clear regular vial. This reverses the correct sequence and can alter the action of the regular insulin in later doses. C is wrong because insulin vials are gently rolled between the palms, not shaken, because vigorous shaking creates bubbles and foam. Shaking does not address the mixing order at all and can interfere with drawing up an accurate dose. When a patient needs both fast-acting and long-acting insulin, combining them in a single syringe saves an extra injection, but the order in which they are drawn up is critical, and getting it wrong can silently ruin future doses. Regular insulin is clear and works quickly to cover meals. NPH is made cloudy by protamine, an additive that slows its absorption and provides longer background coverage. These two insulins differ not just in timing but in chemical composition. If even a tiny amount of NPH is accidentally pushed back into the regular insulin vial, the protamine reacts with the regular insulin and begins converting it into a longer acting form. The fast insulin is no longer reliably fast, and every future dose drawn from that vial is compromised. The protective rule is straightforward. Inject air into both vials first, then draw the clear regular insulin before the cloudy NPH. If any insulin is accidentally transferred between vials during this sequence, it is harmless clear regular reaching the NPH. Watson Okenharten is never protamine laden NPH reaching the regular. Remember, clear before cloudy. This simple sequence keeps the regular insulin vial free from protamine contamination, ensuring that every fast-acting dose behaves exactly as expected, dose after dose. Question 35. A nurse is teaching a client who has a new prescription for tetracycline. Which of the following instructions should the nurse include about taking this medication? Your options are: A. Take it with a large glass of milk. B. Take it with an antacid each time. C. Avoid taking it with dairy products. D. Chew an iron tablet with each dose. Before I reveal it, which one do you think is right? The correct answer is C. Avoid taking it with dairy products. C is correct because tetracycline binds with calcium and other minerals to form non-absorbable compounds, reducing its effectiveness. The nurse should teach the client to avoid taking it with dairy products, antacids, and iron, separating them by adequate time. A is wrong because taking tetracycline with milk causes it to bind with calcium, forming chelates that block absorption. Rather than improving the drug, dairy reduces its effect, so the client should avoid milk near dosing times. B is wrong because antacids contain cations that chelate tetracycline and decrease its absorption. The correct instruction is to separate antacids from the drug, not to take them together, which would interfere with the antibiotic's action. D is wrong because iron also binds tetracycline and prevents proper absorption, so chewing an iron tablet with each dose would undermine therapy. The client should keep iron supplements separated in time from the antibiotic. Tetracycline is an antibiotic with an unusual vulnerability. Certain common substances can trap it in your gut before it ever reaches your bloodstream. Understanding why requires a look at the chemistry of chelation. Chelation is the key mechanism. Tetracycline wraps tightly around metal ions, calcium from dairy, magnesium and aluminum from antacids, and iron from supplements, forming a large, insoluble complex that cannot cross the intestinal wall and is simply lost in the stool. The 4 metal ions to remember are calcium from dairy products, magnesium and aluminum found in antacids, and iron from supplements. Any of these taken at the same time as tetracycline can capture the drug before absorption occurs. Because the problem only occurs when the drug and metal share the gut simultaneously, the practical solution is simple separation in time. Tetracycline is taken on an empty stomach, with dairy, antacids, and iron supplements pushed to a different hour entirely. This same affinity for metal ions also explains why tetracycline is contraindicated in pregnancy and children, where it deposits into forming teeth and bone. Same chemistry, 2 distinct clinical warnings, but in the gut, spacing doses is all it takes to protect absorption. Question 36. A nurse is teaching a client who has a new prescription for an oral muscarinic antagonist, such as oxybutynin for overactive bladder. Which of the following adverse effects should the nurse include in the teaching? Your options are A. Excess salivation, B. Dry mouth and constipation, C. A slow heart rate, D. Increased sweating. What's your answer? Commit to one before I continue. The correct answer is B. Dry mouth and constipation. B is correct because muscarinic antagonists block cholinergic activity, which produces anticholinergic effects such as dry mouth and constipation. The nurse should teach the client about these effects and suggest fluids, fiber, and sugarless candy to relieve the discomfort. A is wrong because excess salivation reflects cholinergic stimulation, which is the opposite of this drug's action. Oxybutynin dries secretions through its anticholinergic effect, so increased saliva is not an effect the client should expect from this medication. C is wrong because a slow heart rate is a cholinergic effect, whereas muscarinic blockade tends to increase the heart rate instead. A slow pulse is therefore not an expected adverse effect of oxybutynin for a client with overactive bladder. D is wrong because anticholinergic drugs reduce sweating and can cause overheating rather than increasing perspiration. Telling the client to expect more sweating would misrepresent this medication, since dry skin and reduced sweating are the actual anticholinergic effects. Oxybutynin works by blocking muscarinic receptors, the docking sites acetylcholine uses to trigger bladder contractions. Understanding this one mechanism explains both why the drug works and every major side effect it causes. The parasympathetic nervous system releases acetylcholine. which binds muscarinic receptors on the bladder wall and triggers contraction. Oxybutynin occupies those same receptors and blocks the signal, so the overactive muscle quiets down. The problem is that muscarinic receptors aren't found only in the bladder. They sit in the salivary glands, the eyes, and the gut as well. A drug taken by mouth reaches all of them equally. By blocking acetylcholine everywhere, oxybutynin dampens the entire rest and digest network. The result is dry mouth, constipation, blurred vision, and in older adults, confusion. These are not random surprises, they are exactly what the mechanism predicts. Patients starting oxybutynin should expect these effects and know simple strategies: sips of water, sugar-free candy, fever, and fluids to stay comfortable. Recognizing oxybutynin as an acetylcholine blocker lets you predict and prepare for everything it does. Question 37. A nurse is reviewing the health record of a client who takes ferrous sulfate and is also prescribed an antacid. Which of the following instructions should the nurse include about timing? Your options are: A. Separate the iron and antacid by an hour. B. Take both medications at the same time. C. Always take the antacid first, then the iron immediately. D. Take the iron only when using the antacid. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Separate the iron and antacid by an hour. A is correct because antacids reduce iron absorption, so the doses should be separated by at least an hour. Spacing them apart preserves the amount of iron the body absorbs and keeps therapy effective. B is wrong because taking both together lets the antacid bind the iron and lower its absorption. This timing reduces the benefit of the supplement, so it is the situation the teaching is meant to avoid. C is wrong because giving the antacid and then the iron immediately afterwards still allows them to interact in the stomach. Without an interval, the antacid continues to reduce iron absorption, so close back-to-back dosing does not help. D is wrong because linking the iron only to antacid use makes no clinical sense and would pair the two drugs that interact. The correct approach separates them in time rather than tying their schedules together. Ferrous sulfate replaces the iron your body needs to build hemoglobin, but getting that iron from your gut into your bloodstream is surprisingly sensitive to conditions. Understanding why helps explain one of the most important timing rules in pharmacology. Iron is absorbed most readily in an acidic environment, which keeps it in the ferrous form the gut can take up. When stomach acid is neutralized, iron shifts toward a form that crosses the intestinal wall much less efficiently. Antacids interfere in two distinct ways. First, they neutralize the stomach acid iron depends on. Second, the metal compounds in many antacids bind iron directly, much as they bind certain antibiotics, trapping it before it can be absorbed. Together, these are a double hit. The fix is straightforward. Separate the iron and the antacid by at least 1 hour, so the stomach is acidic when the iron arrives. Taking iron on an empty stomach and pairing it with a source of vitamin C further maximizes absorption, while the antacid is shifted to a different part of the day. Unlike many medications that absorb regardless of conditions, iron needs an acidic stomach and an absence of binding metals. Spacing iron away from antacids by an hour or more preserves both of those conditions and ensures the supplement can actually do its job. Question 38. A nurse is caring for a client who takes raloxifene and is scheduled for surgery requiring prolonged immobility. Which of the following actions should the nurse anticipate? Your options are: A. Continuing the raloxifene through surgery. B. Doubling the dose the day of surgery. C. Adding a daily aspirin before surgery. D. Stopping the raloxifene before immobility. Which would you go with? Lock it in before the reveal. The correct answer is D, stopping the raloxifene before immobility. D is correct because raloxifene increases the risk of deep vein thrombosis and pulmonary embolism, so to stop before periods of prolonged immobility. The nurse should anticipate discontinuing it and resuming it once the client is fully mobile after surgery. A is wrong because continuing raloxifene through surgery would leave the client exposed to a higher clot risk during immobility. Because of that danger, the medication is held rather than maintained while the client is unable to move freely. B is wrong because doubling the dose would increase the thrombosis risk at the very time immobility already raises it. The appropriate action is to stop the medication before prolonged immobility, not to intensify it for the client before surgery. C is wrong because adding aspirin is not the source identified action for raloxifene before surgery. The correct step the nurse should anticipate is discontinuing raloxifene because of its clot risk during the client's prolonged immobilization. Raloxifene is a selective estrogen receptor modulator. It mimics estrogen in some tissues and blocks it in others. Understanding the split behavior explains both why the drug is useful and where its danger lies. In bone, it acts like estrogen, preserving density and slowing osteoporosis. In breast and uterine tissue, it acts as a blocker, avoiding cancer risk. But in the blood, it inherits estrogen's clot-promoting tendency, and that is the hazard nurses must manage. Estrogen-like drugs nudge blood toward clotting more readily. A clot in a deep leg vein, a deep vein thrombosis, can break loose and travel to the lungs, causing a pulmonary embolism. Raloxifene shares this tendency, and that risk compounds sharply when the patient is also mobile. Prolonged stillness after surgery, long illness, or extended travel slows blood flow and promotes clot formation on its own. Adding a clot-promoting drug on top of that immobility creates a seriously elevated risk. These two factors do not simply add, they compound each other. The nursing action is straightforward. Raloxifene is held before any planned period of immobility, such as major surgery, and restarted once the patient is mobile again. Removing the drug eliminates one half of that dangerous pairing and keeps the clotting risk from becoming critical. Question 39. A nurse is caring for a client receiving a cephalosporin who develops hives, low blood pressure, and difficulty breathing during the infusion. Which of the following actions should the nurse take first? Your options are A. Slow the infusion and continue monitoring. B. Stop the cephalosporin immediately. C. Offer the client a glass of water. D. Reassess the client later in the shift. Don't overthink it. Which one feels right? The correct answer is B. Stop the cephalosporin immediately. B is correct because hives, low blood pressure, and difficulty breathing during a cephalosporin infusion suggest a serious hypersensitivity reaction. The nurse's first action is to stop the medication immediately and then notify the provider to prevent progression to anaphylaxis. A is wrong because merely slowing the infusion allows the offending drug to keep entering the bloodstream during a hypersensitivity reaction. With signs of anaphylaxis present, the cephalosporin must be stopped at once rather than continued at a reduced rate. C is wrong because offering water does nothing to halt an allergic reaction and delays essential care. When a client shows hives, low blood pressure, and breathing difficulty, the priority is stopping the cephalosporin immediately to limit the reaction. D is wrong because waiting to reassess could be fatal during an evolving anaphylactic reaction. These findings demand that the nurse stop the cephalosporin right away and notify the provider rather than postpone evaluation. Anaphylaxis is a life-threatening allergic reaction that can develop within minutes of exposure to a trigger. When a sensitized person receives an allergen directly into a vein, the immune system can misfire catastrophically, flooding the body with chemicals that crash blood pressure and choke off breathing. Immune cells recognize the drug as a threat and release a surge of histamine. This chemical simultaneously dilates and leaks blood vessels, dropping blood pressure, and clamps the muscles around the airways, restricting breathing. Hives erupt as these chemicals reach the skin. The clinical picture of anaphylaxis during an infusion is a triad: hives on the skin, falling blood pressure, and difficulty breathing. Recognizing this cluster during a drug infusion is the key to acting fast. Every other treatment, in 3 counts including epinephrine, depends on one foundational step: stopping the infusion. As long as the drug keeps entering the vein, more allergen feeds the reaction. Giving epinephrine while the allergen still drips in is like fighting a fire without closing the fuel line. Whether the crisis is anaphylaxis, a transfusion reaction, or fluid overload, the opening action is always to stop what is going in. Cut off the source first, then treat what it has caused. Stopping the drug is the foundation everything else builds on. Question 40. A nurse is admitting a client following an acetaminophen overdose. Which of the following medications should the nurse anticipate administering as the antidote for this client? Your options are A. Naloxone, B. Misoprostol, C. Acetylcysteine, D. Calcium gluconate. Got a guess? Lock it in. The correct answer is C. Acetylcysteine. C is correct because acetylcysteine is the specific antidote for acetaminophen toxicity because it protects the liver from the toxic metabolite. The nurse should anticipate administering acetylcysteine to a client who has overdosed on acetaminophen to limit hepatic injury. A is wrong because naloxone reverses opioid effects such as respiratory depression and pinpoint pupils. It has no action against acetaminophen and cannot protect the liver from the hepatotoxic injury an overdose of acetaminophen produces in the body. B is wrong because misoprostol protects the gastric mucosa during NSAID therapy and is used to prevent ulcers. It does nothing for the liver damage caused by an acetaminophen overdose, so it would not serve as the antidote in this situation. D is wrong because calcium gluconate is the antidote for magnesium sulfate toxicity, not acetaminophen poisoning. It does not counter the hepatic injury that defines an acetaminophen overdose and would leave the liver completely unprotected against the toxic metabolite. Acetaminophen is safe at normal doses, but in overdose it can cause fatal liver failure. Understanding why requires tracing exactly how the liver processes this drug and where that process breaks down. The liver converts a small fraction of acetaminophen into a toxic byproduct called NAPQR. Normally, a protective molecule called glutathione neutralizes NAPQR instantly. In overdose, so much NAPQR is produced that it exhausts the liver's glutathione supply entirely. Once glutathione runs out, free NAPQI attacks liver cells directly, killing them in large numbers. Critically, severe liver failure may not appear until a day or more after the overdose, making early treatment essential before visible damage begins. Acetylcysteine works by replenishing glutathione. It provides the precursor the liver needs to rebuild its defenses, so NAPQI is neutralized before it can destroy cells. Its effectiveness depends entirely on prompt administration, and it is worth noting the same molecule has a separate, unrelated use as a mucolytic to thin mucus in the lungs. The key principle is this: acetaminophen overdose kills the liver by depleting glutathione and letting NAPQI run free. Acetylcysteine wins the race by restocking that defense. The sooner it is started, the greater the chance of preventing liver damage entirely. Question 41. A nurse is caring for a client who is receiving doxorubicin. Which of the following findings should the nurse identify as an expected and harmless effect of this medication? Your options are A. Red coloration of the urine. B. Yellowing of the skin. C. Black tarry stools. D. Swelling of the ankles. Which one is it? Pause the video if you need more time. The correct answer is A. Red coloration of the urine. A is correct because doxorubicin causes a harmless red discoloration of the urine and sweat. The nurse should reassure the client that this effect is expected and temporary and does not indicate bleeding or kidney injury. B is wrong because yellowing of the skin suggests liver toxicity and would need reporting, not reassurance. The red urine from doxorubicin is benign, whereas jaundice points to a serious problem requiring evaluation of liver function. C is wrong because tarry black stools indicate gastrointestinal bleeding, a finding the nurse must report rather than expect. Unlike the harmless red urine doxorubicin produces, bloody stools signal a complication that demands prompt attention. D is wrong because ankle swelling can reflect heart failure, a delayed cardiac toxicity of doxorubicin, and must be reported. It is not the harmless expected effect. The benign sign with this drug is reddish urine and sweat. Some medications color the urine, and doxorubicin is the classic example. This deep red chemotherapy drug is excreted through the kidneys, tinting urine reddish or orange for a day or two after each dose. The mechanism is straightforward. Doxorubicin is itself a colored molecule and the body clears it through the kidneys. The red tint is simply the drug and its breakdown products passing out of the body. No bleeding, no injury, no damage to the urinary tract. 3 features define this effect. It is temporary, lasting only a day or two. It is harmless, with no underlying injury, and it is expected, a predictable, normal result of the drug. The clinician's discipline is separating harmless effects from dangerous ones. Reddish urine from doxorubicin needs only explanation. True blood in the urine is a different matter entirely, and the drug's cardiac toxicity is silent, delayed, and potentially fatal, demanding close monitoring. The remedy for patient fear is simple, timely teaching. Tell the patient in advance that the urine will look red, and when it does, they recognize it as expected rather than alarming. Knowing which changes are harmless and which are not is the whole art of using this drug well. Question 42. A nurse is administering a unit of packed red blood cells when the client reports chills and low back pain and develops a fever. Which of the following actions should the nurse take first? Your options are A. Slow the rate of the transfusion. B. Administer an antipyretic medication. C. Recheck the client's identification band. D. Stop the transfusion. Take a second. Which answer would you pick? The correct answer is D. Stop the transfusion. D is correct because chills, fever, and low back pain suggest an acute hemolytic transfusion reaction, which is life-threatening. The nurse's first action is to stop the transfusion to limit the amount of incompatible blood infused. Then keep the line open with sodium chloride. A is wrong because slowing the rate still allows incompatible blood to enter the client, continuing the hemolytic reaction. The priority is to stop the transfusion completely, because even a reduced flow keeps the harmful blood entering the bloodstream. B is wrong because giving an antipyretic treats the fever, but does nothing to halt the dangerous reaction in progress. The first action is to stop the transfusion, since the source of the chills, fever, and back pain is the blood being infused. C is wrong because rechecking the identification band is important, but it comes after the transfusion is stopped to protect the client. Stopping the infusion first prevents more incompatible blood from worsening the hemolytic reaction the client is showing. When incompatible blood enters the body, the immune system launches an immediate and potentially life-threatening attack on the transfused red cells. Understanding why this happens and what to do is essential for anyone caring for a patient receiving blood. When mismatched red cells enter the bloodstream, the recipient's antibodies immediately recognize foreign antigens on their surface and destroy them. This releases harmful breakdown products that flood the kidneys and circulation, which is why even a small volume of wrong blood can trigger a violent reaction. The destruction of red cells produces a recognizable cluster of early signs: chills and rising fever, pain in the lower back or flank where the kidneys are struggling with breakdown products, a racing heart, and falling blood pressure. These findings during a transfusion are an alarm that must not be ignored. The mechanism dictates the response. As long as incompatible blood keeps flowing, the reaction worsens with every drop, or tease. So the absolute first step is to stop the transfusion. Then the line is kept open with saline to protect the kidneys, and the provider and blood bank are notified while the blood is rechecked against the patient. Nothing matters more than stopping the transfusion immediately. Cutting off the source of incompatible cells is what keeps a dangerous reaction from becoming a fatal one. Question 43. A nurse is monitoring a client receiving gentamicin. Which of the following findings should the nurse report to the provider as a sign of nephrotoxicity? Your options are A. A small increase in appetite, B. A rise in blood urea and creatinine, C. Pink coloring of the cheeks, D. A lower resting respiratory rate. Before I reveal it, which one do you think is right? The correct answer is B. A rise in blood urea and creatinine. B is correct because aminoglycosides can cause nephrotoxicity, leading to acute tubular necrosis. A rise in blood urea, nitrogen, and creatinine signals declining kidney function. So the nurse should report these findings and monitor intake and output closely. A is wrong because a modest increase in appetite is reassuring and unrelated to kidney damage. Nephrotoxicity from gentamicin is reflected in rising kidney laboratory values and reduced urine output, not in improvements in how much the client eats. C is wrong because pink cheeks indicate normal coloring and do not point to renal injury. The nurse identifies nephrotoxicity by elevated kidney markers such as creatinine, along with cloudy urine, rather than by the client's facial appearance. D is wrong because a slower resting respiratory rate does not reflect aminoglycoside kidney toxicity. The warning findings are increases in blood urea, nitrogen, and creatinine, which show that gentamicin is impairing the client's kidney function. Gentamicin is a powerful aminoglycoside antibiotic used for serious infections. Its effectiveness comes with a trade-off. It carries two significant toxicities that clinicians must actively monitor throughout treatment. The drug is toxic to two organs, the kidneys, causing nephrotoxicity, and the ears, causing ototoxicity with ringing, hearing loss, or dizziness. Both must be watched, but kidney damage is tracked through routine blood tests. The kidneys both clear gentamicin from the body and accumulate it in tubule tissue. This direct injury to tubule cells reduces the kidney's ability to filter waste, causing blood urea, nitrogen, and creatinine to rise, the laboratory signature of nephrotoxicity. Monitoring focuses on four markers: blood urea, nitrogen, creatinine, drug blood levels, and urine output. Crucially, creatinine often rises before the patient feels anything, making routine monitoring essential rather than optional. A climbing creatinine is the kidney's early warning. Catching that trend allows the provider to adjust the dose, lengthen intervals, or switch antibiotics, protecting the kidneys before the damage becomes severe or irreversible. Question 44. A nurse is caring for a client who is receiving acetylcysteine by inhalation as a mucolytic. Which of the following adverse effects should the nurse monitor for during administration? Your options are A. Constipation, B. A slow heart rate, C. Bronchospasm. D. Increased blood glucose. What's your answer? Commit to one before I continue. The correct answer is C. Bronchospasm. C is correct because acetylcysteine can trigger bronchospasm when inhaled, especially in clients who have airway disease. The nurse should monitor for wheezing and respiratory difficulty and be ready to stop the drug and notify the provider if bronchospasm occurs. A is wrong because constipation is not an effect of inhaled acetylcysteine. The respiratory concern with this mucolytic is bronchospasm, which is the adverse effect the nurse must watch for closely during administration to a client with airway disease. B is wrong because a slow heart rate is not characteristic of acetylcysteine. The drug may instead cause a faster heart rate. Bronchospasm, rather than a slow pulse, is the priority adverse effect the nurse should monitor for during inhalation. D is wrong because increased blood glucose is not associated with acetylcysteine. Monitoring during inhalation should focus on respiratory effects, such as bronchospasm, rather than on any change in the client's blood glucose level while receiving this mucolytic. Acetylcysteine has a second role beyond overdose treatment. When inhaled as a mist, it acts as a mucolytic, a drug that breaks apart thick, sticky mucus so patients can clear their airways. Thick mucus gets its stickiness from disulfide bonds, chemical links that knit long molecules into a dense web. Acetylcysteine breaks those bonds, unraveling the web and turning thick secretions into thinner, more fluid mucus that can be coughed up or suctioned away. The main adverse effect follows directly from putting an irritating substance into the airways. Acetylcysteine has a sharp sulfur smell, and the mist irritates the airway lining. In susceptible patients, especially those with asthma, that irritation causes the muscles around the airways to clamp down, a reaction called bronchospasm. Because of this risk, a bronchodilator may be given before or alongside the drug to keep airways relaxed. The clinician monitors for wheezing and tightness throughout administration and is prepared to stop treatment and respond if bronchospasm occurs. The key contrast is route and purpose. Swallowed or infused, acetylcysteine reverses acetaminophen overdose. Inhaled, it thins airway mucus, but can paradoxically tighten the very airways it is meant to help. Question 45. A nurse is teaching a client who has a new prescription for colsevelam. Which of the following instructions should the nurse include to manage a common adverse effect? Your options are A. Increase fiber and fluids in your diet. B. Limit your daily fluid intake. C. Avoid foods that contain calcium. D. Take the medication at bedtime only. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Increase fiber and fluids in your diet. A is correct because bile acid sequestrants such as colsevelam commonly cause constipation. The nurse should instruct the client to increase dietary fiber and fluids, which promote regular bowel movements and help relieve this frequent adverse effect of the medication. B is wrong because reducing fluids would worsen constipation, the very problem this teaching aims to prevent. Because colsevelam slows the bowel, the client needs more fluid and fiber, not less, to keep stool moving comfortably. C is wrong because avoiding calcium is unrelated to this drug's bowel effect and is not part of correct teaching. To manage the constipation that colsevelam often causes, the client should add fiber and fluids to the diet. D is wrong because a bedtime-only schedule does not address constipation and is not how this drug is timed. The instruction that manages the common GI effect is to boost fiber and fluids, which help maintain regular bowel function. Colsevelam is a bile acid sequestrant that lowers cholesterol entirely within the gut. It never enters the bloodstream. Because it stays in the digestive tract, its side effects play out there too, and the most common one patients notice is constipation. The drug works by grabbing bile acids in the intestine and carrying them out in the stool. This forces the liver to convert cholesterol into replacement bile acids, which is how blood cholesterol falls. But that same bulky, water-grabbing resin also stiffens stool and slows bowel movement. Constipation arises from two overlapping effects. Bile acids normally keep stool soft and moving, and removing them hardens things. The physical bulk of the resin itself further slows the bowel's rhythm, leaving stool infrequent and difficult to pass. The good news is that this side effect is usually preventable rather than a reason to quit. Boosting dietary fiber and fluid intake from day one softens the stool and keeps the bowel moving, counteracting the drug's effects. Teaching patients these habits up front helps them stay on a medication that is genuinely benefiting their cholesterol. Keep this contrast clear. Colsevelum causes two gut-based problems. It can block absorption of other drugs, solved by spacing doses apart, and it causes constipation, managed with fiber and fluids. Both issues come from the same gut-bound molecule, and both have straightforward solutions. Question 46. A nurse is caring for a client who is receiving ondansetron for chemotherapy-induced nausea. The nurse should monitor the client for which of the following as a serious adverse effect. Your options are A. A slow respiratory rate, B. Increased salivation, C. Constricted pupils, D. A prolonged QT interval. Which would you go with? Lock it in before the reveal. The correct answer is D. A prolonged QT interval. D is correct because ondansetron can prolong the QT interval, which may lead to a serious dysrhythmia called torsades de pointes. The nurse monitors clients who have cardiac disorders or electrolyte problems for this heart rhythm change. A is wrong because a slow respiratory rate is not a recognized effect of ondansetron. It points toward opioid or sedative effects. So it does not fit the cardiac risk the serotonin antagonist actually carries. B is wrong because ondansetron does not increase salivation. Drooling reflects cholinergic activity, which is the opposite direction from this drug's profile. So it is not the adverse effect to watch for. C is wrong because constricted pupils suggest opioid effects rather than a serotonin antagonist. The dangerous concern with ondansetron is a heart rhythm change, so a pupil finding misses the real adverse effect. Ondansetron is a serotonin type 3 receptor blocker used to prevent chemotherapy-induced nausea and vomiting. It works by shutting down the serotonin signal that the gut and brain's vomiting center release in response to chemo. Chemotherapy triggers serotonin release from cells lining the gut. That serotonin binds to 5-HT3 receptors on nerve endings and sends a vomiting signal to the brainstem. Ondansetron blocks those receptors before the signal can travel. Ondansetron's serious adverse effect is QT prolongation. It is SAW. It lengthens the time the heart's ventricles take to reset between beats. A stretched QT interval creates an electrical window during which a dangerous, potentially fatal arrhythmia can spark. The risk is amplified when ondansetron is combined with other QT prolonging drugs, or when potassium or magnesium levels are low. In high-risk patients, the ECG and electrolytes are monitored because the interval can stretch silently, with no symptoms, until a lethal rhythm strikes. Ondansetron is highly effective and generally well tolerated, but its danger hides in the heart's electrical timing, not the gut. Knowing that its rare grave risk is a prolonged QT interval, gut, caught on ECG, worsened by electrolyte imbalance, is what keeps a vital drug safe. Question 47. A nurse is teaching a client who has a new prescription for sublingual nitroglycerin for angina. Which of the following instructions should the nurse include? Your options are A. Swallow the tablet with a full glass of water, B. Place the tablet under your tongue to dissolve. C. Chew the tablet thoroughly before swallowing. D. Take the tablet only after the pain is severe. Don't overthink it. Which one feels right? The correct answer is B. Place the tablet under your tongue to dissolve. B is correct because sublingual nitroglycerin is absorbed through the oral mucosa and is ineffective if swallowed. The nurse should instruct the client to place the tablet under the tongue and let it dissolve at the first sign of chest pain. A is wrong because swallowing the tablet sends it through the digestive tract, where it is inactivated before it can relieve angina. For the drug to work quickly, it must dissolve under the tongue and absorb directly into the bloodstream. C is wrong because chewing and swallowing destroys the benefit of the sublingual route, which depends on absorption through the mucosa. The tablet should be placed under the tongue, not chewed, so it can act rapidly on the chest pain. D is wrong because waiting until pain is severe delays relief. The client should use nitroglycerin at the first indication of chest pain. The correct technique is to let the tablet dissolve under the tongue promptly, rather than holding off until pain peaks. Sublingual nitroglycerin is a fast-acting rescue treatment for angina, thus the crushing chest pain that occurs when the heart muscle isn't getting enough blood. Understanding why this route works so well starts with how the drug reaches the bloodstream. The lining under the tongue is thin and richly supplied with blood vessels. A tablet placed there dissolves and passes its drug almost directly into the bloodstream within minutes, completely bypassing the digestive tract and the liver's first-pass breakdown that would destroy most of the dose. Speed is everything during an angina attack. The sublingual route absorbs the drug in minutes, while a swallowed tablet would be largely broken down by the liver before reaching the heart. Far too slow to abort an attack in progress. Proper technique matters. The tablet is placed under the tongue and allowed to dissolve. Tingling, burning, and a mild headache are normal signs the drug is working if pain persists after a dose. The standard guidance allows repeating at set intervals, but chest pain that won't respond may signal a heart attack. Not ordinary angina. The key contrast is between the two forms of nitroglycerin. The sublingual tablet is a rescue, taken the moment pain strikes to abort an attack. The skin patch is prevention, worn steadily to keep attacks from occurring. Matching the right form to the right moment is the heart of using nitroglycerin well. Question 48. A nurse is teaching a client who has osteoarthritis and a shellfish allergy about glucosamine. Which of the following instructions should the nurse include? Your options are: A. This supplement will improve your night vision. B. This supplement is used to treat high blood pressure. C. Use this supplement cautiously because of your shellfish allergy. D. This supplement lowers your blood sugar. Got a guess? Lock it in. The correct answer is C. Use the supplement cautiously because of your shellfish allergy. C is correct because glucosamine is used for osteoarthritis, but should be used cautiously in clients who have a shellfish allergy. The nurse includes this caution because of the client's allergy history. A is wrong because glucosamine does not improve night vision in any way. Its use targets cartilage and joint health for conditions such as osteoarthritis, so this claim does not reflect what the supplement actually does for the client. B is wrong because glucosamine is used for joint conditions such as osteoarthritis, not high blood pressure. Describing it as a blood pressure treatment misstates its purpose, so this instruction would give the client inaccurate information. D is wrong because glucosamine is not used to lower blood sugar and has no such effect. The relevant teaching for this client centers on the shellfish allergy caution, not a glucose-lowering action the supplement does not possess. Glucosamine is a popular supplement taken to ease the joint pain and stiffness of osteoarthritis, a condition where cartilage gradually wears down, Understanding who needs to be careful with it comes down to how the supplement is actually manufactured. Most commercial glucosamine is extracted from the shells of shellfish, shrimp, crab, and lobster, while the allergy-causing proteins are concentrated in the flesh rather than the shell. Trace amounts can remain in the final product, making cross-reactivity a real possibility. For a patient with a known shellfish allergy, the guidance is threefold. Use glucosamine cautiously, discuss the risk with a healthcare provider, and look for a glucosamine product derived from a non-shellfish source if one is available. This is an important nuance. A shellfish allergy calls for caution and informed decision-making, not an automatic prohibition, because supplements are regulated less strictly than prescription drugs. The responsibility for checking the source and weighing the risk falls on the patient and their clinician. Whenever you see glucosamine paired with a shellfish allergy, the teaching is measured caution, not a hard stop. Know the source, involve the provider, and make an informed choice. Question 49. A nurse is teaching a client who has a new prescription for clonidine. Which of the following instructions should the nurse include in the teaching? Your options are: A. Stop the medication if you feel dizzy. B. Take the medication only when needed. C. Double the dose if you miss one. D. Do not stop the medication abruptly. Which one is it? Pause the video if you need more time. The correct answer is D. Do not stop the medication abruptly. D is correct because stopping clonidine abruptly can cause severe rebound hypertension. The nurse should instruct the client not to discontinue the drug suddenly and to taper it only under the provider's direction to prevent a dangerous spike in blood pressure. A is wrong because stopping the drug at the first dizziness could trigger rebound hypertension. Dizziness should be managed with safety measures and reported, but the central teaching is to avoid suddenly halting clonidine, which this option dangerously suggests. B is wrong because clonidine is taken on a regular schedule to keep blood pressure controlled, not as needed for symptoms. Using it only occasionally would leave pressure uncontrolled and invites rebound effects. So this instruction is incorrect. C is wrong because doubling a missed dose can cause excessive hypertension and sedation and is never advised. The instruction the nurse stresses is consistent use without abrupt discontinuation, not making up doses by taking extra medication. Clonidine lowers blood pressure by quieting the sympathetic nervous system in the brain. Because the body adapts to its steady presence, how a patient manages this drug day-to-day matters enormously. Clonidine acts in the brainstem to hold the sympathetic nervous system in check, slowing the heart and relaxing blood vessels. When the drug is present consistently, that suppression holds steady. Patients are taught 4 practical habits: taking the drug on a strict schedule, rising slowly from sitting or lying to avoid falls, easing dry mouth with sips of water or sugar-free candy, and keeping refills current so the supply never runs out. If clonidine is stopped suddenly, the prime sympathetic system rebounds hard. Blood pressure can surge to dangerous heights, accompanied by a pounding heart, sweating, and headache, making abrupt discontinuation the central hazard the teaching guards against. Drowsiness, dry mouth, and dizziness are manageable nuisances. Sudden discontinuation is the genuine danger. The no sudden stopping rule is non-negotiable, and every other habit exists to support it. Question 50. A nurse is teaching a client who has a new prescription for nitrofurantoin. Which of the following information should the nurse include about an expected change during therapy? Your options are: A. The urine may turn a brownish color. B. The teeth will become permanently white. C. The skin will develop a blue tint. D. The hair will change to a red shade. Take a second. Which answer would you pick? The correct answer is A. The urine may turn a brownish color. A is correct because nitrofurantoin commonly turns the urine a rust yellow to brown color, which is an expected and harmless effect. The nurse should reassure the client that this discoloration does not indicate a problem and is anticipated with therapy. B is wrong because nitrofurantoin does not whiten the teeth. In fact, it can stain them if capsules are opened. The expected change the nurse teaches about is the brownish urine, not any whitening of the teeth. C is wrong because a blue skin tint is not associated with nitrofurantoin and would suggest another problem such as poor oxygenation. The harmless expected effect of this drug is brown discoloration of the urine. D is wrong because nitrofurantoin does not alter hair color. The anticipated and benign change the nurse should mention is the brownish coloring of the urine, which clients may otherwise mistake for a sign of injury. Nitrofurantoin is an antibiotic that works directly in the urinary tract, which means it and its breakdown products are concentrated by the kidneys and excreted into the urine. That concentration is precisely what makes it effective against urinary tract infections. As the drug flows through, it tints the urine dark yellow, brown, or rust. That brownish color is the visible sign that the medication is being delivered exactly where it needs to act. Memorised, there is no damage behind it. The danger is not the color itself, but how a patient might react to it. Dark brown urine can suggest blood or liver trouble, so an unwarned patient may panic and stop the antibiotic early. And stopping early lets the infection rebound and breed resistance. The fix is simple. Warn the patient at the start. Explaining that the color change is expected and harmless turns a frightening surprise into a non-event, supports completion of the full course, and applies equally to any drug that colors urine, sweat, or tears. Keep these two facts distinct. The brown urine is purely cosmetic, worth teaching so it does not frighten. But nitrofurantoin's dependence on healthy kidneys is a genuine safety matter. A good clinician reassures about the color while staying alert to the kidney caution.
You have reached the end of our first question set. For the free complete exam preparation, visit our website, link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.